important questions that they were asked. Again, in appendix, you cannot go to the exam without knowing about acute appendicitis, right? So we had questions on acute appendicitis. So everything was asked in acute appendicitis, from its pathophysiology to that of causative agents, how do you diagnose it, management, and everything. So talk about acute appendicitis was a question. Then there was a question on rectal cancer, diagnosis and management. Then there was a question on hemorrhoids and the ano, that's your fistulas, the fistula-in-ano. So our objective is going to be to talk about all these 4 topics. It is going to be your acute appendicitis, your rectal cancers, your hemorrhoids, as well as your fistula-in-ano, right? So without wasting any further time, let's kickstart our discussion on acute appendicitis. So we'll be talking about all the important points in relevance to that of acute appendicitis. So we're talking about all the important points which are going to be in relevance with that of the acute appendicitis, right? Now, when you talk about acute appendicitis, it is classically described as the acute inflammation. It is an acute inflammation of appendix. It is going to be an acute inflammation of appendix, which is going to present to you as appendicitis. We'll see what are the reasons for the acute inflammation of that of the appendix, right? So when you talk about what are the causative or the pathophysiology, remember the pathophysiology of the acute appendicitis is going to be an inflammatory disorder, but here you will see the pathogen which are going to be present. It is going to be a combination of both aerobic as well as the anaerobic bacteria will be present. So when they talk about aerobic, remember usually the organism which is responsible for acute appendicitis, which is aerobic, is going to be E. coli, and anaerobic is going to be your bacteroids, right? Now, based upon how it is going to present, I can divide the pathophysiology into 2 categories. One is the obstructive, another one is a non-obstructive form. One is the obstructive form of the acute appendicitis, another one is the non-obstructive form. Another one is the non-obstructive form of the acute appendicitis. Now, it's a simple concept that if the appendicular lumen gets obstructed, the secretions are going to pull up in the appendix. Like in simple context, if you take this as the representation of the ascending colon, let's say this is the representation of the ascending colon that you have. This is where you have the cecum, and the junction between the cecum and the terminal ileum, you have the appendix, and this is your terminal ileum, right? You will notice that these bands which are present, which are called as the Teniae Coli, I hope everybody knows that 3 Teniae Coli which are present, all of them are going to be merging at the base. So one is going to be on the anterior surface, one on the posterior, another one is in lateral. All these Teniae Coli, when they merge together, they actually combine at the base of the appendix. They usually combine at the base of the appendix that you see. Now, usually the appendix can be present in different positions that you have. Remember the most common position, just for the sake of understanding. If I talk about the appendix, the most common position of the appendix is going to be retrocecal. It is behind the cecum that you'll see. It is going to be retrocecal. When you talk about the blood supply, you take this as a representation of the superior mesenteric artery. The superior mesenteric artery has 3 branches: the ileocolic artery, the middle colic artery, the right colic artery, and the middle colic artery. There are 3 vessels which are present. This is what we call it as the ileocolic artery. This happens to be the right colic artery, and this happens to be the middle colic artery. We all know the middle colic artery. Will again divide them into the right branch of the middle colic artery and the left branch of the middle colic artery. So this is your right branch of the middle colic artery. This is your left branch of the middle colic artery. This is your left branch of a middle colic artery. The ileocolic artery, which is going to come across and supply to that of the terminal ileum. Along with that, it will also supply to a part of the cecum, but more importantly, the ileocolic artery will also supply. The ileocolic artery will also supply to that of the appendix. Now, what is interesting about the appendix is, if I just make it a little bit more dramatic about it, you will have a retrograde integration. Now, what do you mean by this is, you see this is the terminal ileal vessel. Now, from here, the terminal ileal vessel, you will see there is the branch that is going to come across, and it will insert the appendix at its tip. And this is what we call it as your appendicular artery. So the appendicular artery technically is a branch of the ileocolic artery, which is going to go and attach to the appendix, but it is not coming from the base. The supply is not coming from the base. The supply is coming from the tip of the appendix, and this happens to be the appendicular lumen. This is the appendicular lumen that is present. Now, we all know the blood supply in the entire bowel usually comes from the mesenteric border. So, this happens to be the mesenteric border through which you will see the blood supply is going to come. So, for the appendix, this becomes the mesenteric border. So, it is the mesenteric border through which you will get the blood supply. So, that was the mesenteric border of the appendix. That's the mesenteric border of the appendix, which is going to be present across here, right? Now, when we say the obstructive form, usually we have something called as a fecolith. Now, in a fecolith, you will see the stools are going to go and get stuck into the appendicular lumen. Now, if the stools are going to get stuck, what is going to happen? All the secretions which are going to be present will start pooling inside the appendix. Because of this, the lumen pressure of the appendix will increase, and that increase in luminal pressure will see when the pressure inside the lumen of the appendix will increase, it will not allow the blood to flow into the appendicular wall, hence causing hypoxia and ischemia, resulting in acute appendicitis, right? So this is how it is going to result in acute appendicitis. That's the basic pathophysiology. This is an obstructive form. Now, this obstruction can be because of various reasons. So what are the causes when you look at the obstructive form of the acute appendicitis? Now, the obstructive form of the acute appendicitis, number one, it is secondary to fecolith. This is the overall most common. It can be because of the parasites, example like the vermicularis. So, it can be because of a parasite, that is a vermicularis. It can be because of a tumor, example like carcinoid tumors. It is the carcinoid tumors. It can be because of malignancy, that is your cecum. It can be because of Crohn's disease as well. The non-obstructive form is secondary to hypoxia or ischemic nature. It can be because of secondary to hypoxia or that of the ischemic nature, right? So these are the components that you're going to look in the form of the acute appendicitis, right? Now, what are the clinical features? How does a patient present to you of the acute appendicitis? So talk about the clinical features. Clinical features of acute appendicitis. Now, classically, when you talk about the acute appendicitis, we all know the appendix is present in the right iliac fossa. We all know the appendix is present in the right iliac fossa. So, for the examiner, you can just draw a small representation of the abdomen, and this is the umbilicus, and this is the midline that you have. So this is the midline that you have. So you can say this point that you have is your anterior superior iliac spine, and you can draw a line joining these two, right? And you can say there is something called as a McBurney's point. The McBurney's point is going to present from the medial 2/3 and the lateral 1/3. This corresponds. This is what we call it as the McBurney's point. This McBurney's point corresponds to the base of the appendix. This corresponds to the base of the appendix. So this is basically fixed. Now why it is important is this is the site for maximum tenderness. This is the site for maximum tenderness. So the McBurney's point corresponds to the base of the appendix, and this is the most common site or the maximum site of the tenderness. How do you know it is from anterior superior iliac spine to the umbilicus? You draw a line, and then between the the border between the medial 2/3 and the lateral 1/3, this junction is what we call it as the McBurney's point. It corresponds to the base of the appendix. This corresponds to that of the base of the appendix, right? Now, what are the clinical features that you're going to experience? Now, patient will present to you. See, appendicitis is an inflammation of ruber-callus dollar tumor. So these are the presenting features that you will see. So patient is going to have pain in the right iliac fossa. Patient will have pain in the right iliac fossa. It will be associated with fever, and patient will also have anorexia. So there is pain, fever, and anorexia is the component that you will present, that you will see in the patient of acute appendicitis. Few patients of acute appendicitis can also present to you with diarrhea, but that is when the pelvic in position. If the appendix is pelvic in position, if it is pelvic in position, due to irritation of the bowel, it can also result in diarrhea. It can also result in diarrhea. So when a patient presents to you with these features, I would like to examine. So on examination, what are the findings that you're going to see? On examination, the first finding, there will be right iliac fossa tenderness. Along with that, there will be right iliac fossa rebound tenderness. So there is right iliac fossa tenderness is noticed. Then there is right iliac fossa rebound tenderness will be noticed. There will be rebound tenderness will be noticed. See, in the clinical features now, along with anorexia, also add these patients will also have nausea as well as vomiting. That is because of the ileus secondary to appendicitis. Okay? So you have the right iliac fossa tenderness, there is rebound tenderness, patient won't let you touch, so there is presence of guarding. Patient won't let you touch the abdomen, there will be presence of guarding as well. Now, because obviously it's an inflammatory disorder, there is pain, and that pain will also cause tachycardia, so will be increased heart rate. The patient is also going to have tachycardia. Then that can be secondary to fever, pain, and all that is taken into consideration. Now, there are certain clinical signs that you should mention in your exam. Now, what are the clinical signs that you can see? So I'll just quickly mention the clinical signs in acute appendicitis. So we'll talk about the clinical signs. Now, the clinical signs which are associated in acute appendicitis, number one, you have the Rovsing sign. Now, what is this Rovsing sign? Rovsing sign, when you press in the left iliac fossa, because the content is being shifted into right side, obviously pressure in the right iliac fossa will increase, hence causing pain. So pressing on the left iliac fossa causes increase in pain of the right iliac fossa, is what we call it as the Rovsing sign. Second one that you have is what we call it as the psoas sign. It is when it is going to be touching the psoas muscle, right? Psoas sign is positive when the appendix is retrocecal in position. When it is retrocecal in position, it is going to rub onto the psoas muscle, right? So this is going to be present as pain on hyperextension of the hip. So presence of pain on hyperextension. Pain on hyperextension of the hip is what we call it as the psoas sign positive, right? Next one you have is the obturator sign. Next one that you have is the obturator sign. Now again, it is if the appendix is pelvic in position. This is for appendix which is pelvic in position. Now if the appendix is pelvic in position, the pain on the right iliac fossa will increase on internal rotation of the hip. So here I can say the pain increases in right iliac fossa on the internal rotation of hip. On the internal rotation of the hip. That is your obturator sign. Another one that you will see is your pointing sign. Pointing sign, here the patient is going to use the index finger to point the maximum site of tenderness which corresponds to that of the McBurney's point. So patient uses index finger to localize maximum site of tenderness. Maximum site of tenderness, that is your pointing sign, which corresponds to the McBurney's point. Which corresponds to that of the McBurney's point, right? The last one that is going to be there is going to be your Bestedy sign. Bestedy sign, if you inflate the rectum or you do a per rectal examination, so on digital rectal examination, there will be pain increase in right iliac fossa. The pain increase in right iliac fossa, that is your Bestedy sign. So these are the clinical signs on the acute appendicitis that you should be aware of. Now, obviously, when the patient comes to you with appendicitis, you would like to evaluate in terms of investigation. In terms of investigation, you have to get the CBC, that is complete blood test. You have to get the USG of the abdomen and pelvis. And to confirm, you can go ahead with CECT abdomen. But more importantly, clinically, we have a scoring which is called as the Alvarado scoring system for acute appendicitis. So looking at the Alvarado, it is the Alvarado scoring for acute appendicitis. Now, the mnemonic to remember the components of the Alvarado scoring system is what we call it as the mantle. So we'll talk about mantrals as the mnemonic to remember all the important points about the Alvarado scoring system. Now, according to the Alvarado scoring system, the first set that you will see are considered to be as symptoms. Now, the symptoms that you will see will be presenting with MANN, that is your mantral command. Now, M stands for migratory right iliac fossa pain. It is going to be a migratory right iliac fossa pain. That means when the patient will complain, initially patient will say there is a diffuse abdominal pain and later on it localized to the right iliac fossa, there is a migratory right iliac fossa pain is noticed. Anorexia is one of the most consistent finding in acute appendicitis. Along with that, there will be nausea and vomiting. Along with that, there will be nausea and vomiting. Then the second one that you will see is going to be signs. So what are the signs that you will see? That is mantral, that is TRE, are the signs that you will see in mantral. Not the C. T stands for right iliac fossa tenderness. This is a right iliac fossa tenderness. R stands for rebound tenderness. R stands for rebound tenderness. And E stands for, that is fever, that is elevated temperature. This is an elevated temperature. This is an elevated temperature. E stands for elevated temperature. So done with the symptoms, done with the sign, and then you have the lab values. So MAN is done, TRE, so mantral is done, LS is left. So L and S. Now L stands for leukocytosis. It is leukocytosis, that is elevated WBC counter, and S stands for shift to left. It is a shift to left. Now all the scoring system or the components are given to give you a proper scoring for all of them. So let's talk about what is the score that they are going to get out of it. So the score that is going to be given for migratory, see, for all symptoms you can remember, I will give you an easy way to remember. Symptoms is going to be 1. So migrate, that is pain, anorexia, nausea will have a score of 1, 1, 1. Signs, 1 will have a score of 2 and the rest is going to have a score of 3. So you'll see the tenderness is going to be your score of 2 and the rest is going to be a score of 1. Same here. In your lab, leukocytosis will have a score of 2, shift in left is going to be 1. So when you look at the total score is going to be of 10. So when you look at the mantrals, the total score, when you look at the total score for mantrals is going to be 10. And 10 is confirmatory for acute appendicitis, right? So 10 is going to be confirmatory for your acute appendicitis, right? So normally we say at what component would you suspect it, when would you confirm it and all that. Remember, confirmation of acute appendicitis, confirm acute appendicitis, if a score is more than or equal to 9. Highly suggestive or highly likely of acute appendicitis if a score is more than or equal to 7 but less than 9. When we do a CT, so CCT abdomen is to be considered when you are in doubt. Now CCT abdomen, when a score is less than or equal to 6, to confirm that of acute appendicitis, you have to go ahead with CCT abdomen. You have to go ahead with CCT abdomen, right? Now, just to summarize the whole component that we have learned, what are the other differential diagnoses that you can look in the context of acute appendicitis, right? So, differential diagnosis. So differential diagnosis for acute appendicitis. For acute appendicitis. So the differential diagnosis for acute appendicitis, especially in children, it is going to be the Meckel's diverticulum. It is going to be the Meckel's diverticulum. It can be seen in secondary to ureteric colic. It can be secondary to ureteric colic, especially if there's a torsion testis on the right side. So right testicular torsion. Right testicular torsion. It can also be mimicked by pancreatitis, where you have diffuse abdominal pain. In females, it can be secondary to PID, that is a pelvic inflammatory disease. Secondary to ectopic pregnancy. So especially in fertile females, always get a UPT done before going for any further investigation, that is a urine pregnancy test, to rule out if the patient is pregnant or not. So ectopic pregnancies are another important component. Torsion or ruptured ovaries. Torsion or ruptured ovaries, right? And the last one is endometriosis. So these are the differential diagnosis of your acute appendicitis that you should mention when you're going with the investigatory property. Okay? So basically the cross-sectional imaging is going to rule out all these components, and then you will confirm that the patient is having an acute appendicitis, right? Now, how do you manage? The management of the acute appendicitis depends upon that what is the presentation. Is it only an acute appendicitis? Is there a perforated appendix, or is there an appendicular mass? So the management depends. Are you dealing with acute appendicitis? Is there a perforated appendix? Or if there is an appendicular mass? If there's an appendicular mass. Now, if the patient presents to you with simple acute appendicitis, then the management is straightforward. It has to be surgery, and surgery is going to be appendicectomy. It is going to be appendicectomy. Now, when you talk about the appendicectomy, what are the common incisions that you can talk about? So we have two options. You can go ahead with open appendicectomy as well as your laparoscopic appendicectomy. So either you can go ahead with open appendicectomy, or you can go ahead with laparoscopic appendicectomy. Preferred one as of today is going to be a laparoscopic appendicectomy. Now, in an open appendicectomy, what are the incisions that you have? So we have the grid iron incision. So three standard incisions. Number one is going to be the grid iron incision. Then you have the Rutherford, Morrison's incision. And the cosmetically acceptable is your Lanz incision. So three incision: grid iron, Rutherford, as well as your Lanz incision. Now, what is interesting about each one of them is the grid iron is a muscle splitting incision. It is your muscle splitting incision. Rutherford Morrison is your muscle cutting incision. And Lanz is a cosmetic incision. Lanz is also muscle splitting, but it is more cosmetic, right? So where would you put the incision? Now, if you take this as the representation of the abdominal wall, this is the appendix. Now, as we know, the McBurney's point is going to lie somewhere here. That is the junction between the lateral 2/3 and the medial, medial 2/3 and the lateral 1/3. So when you talk about the McBurney's point, so if you join these two lines, this is going to be the medial 2/3 and the lateral 1/3. You will see the McBurney's point, right? Now the grid iron incision is going to be like this. So this is the incision, which is called as a grid iron incision, which is a muscle splitting. Now, what is a Rutherford Morrison's incision? It is nothing spectacular. If you extend the grid iron incision laterally to gain more access, right? Same grid iron incision, if I extend my incision more laterally and cutting the muscle to gain more access, it will become Rutherford Morrison's. Whereas when you talk about the Lanz incision, if you draw, this is your mid-clavicular line, right? So usually it is going to cross your McBurney's point. At this point, if you give a transverse incision, a transverse incision at this point is your Lanz incision. As simple as that, right? So three incisions that we spoke across here. Number one is your grid iron incision. Number one is your grid iron incision. which is here. Then you have the Rutherford, which is here. And then you have the Lanz incision, which is here. Right? All these three are the incisions that you are supposed to keep it for your acute appendicitis. For your acute appendicitis. Clear? Now, if you have a patient who is presented with your perforated appendix. For a perforated appendix, patient would present to you with signs and symptoms. The signs and symptoms of peritonitis. There be signs and symptoms of peritonitis. Right? Now, in signs and symptoms of peritonitis, you can see there is presence of abdomen, there is presence of guarding. There will be presence of rigidity in the abdominal wall. There will be diffuse abdominal pain. There will be this diffuse abdominal pain. Right? For these patients, you have to take the patient for exploratory. Take the patient for exploratory laparotomy. Take the patient for exploratory laparotomy. Now, if there is an abscess, if there is an appendicular abscess, then I am going to place the abdominal drain and exit. If there is presence of gangrene, if the gangrene is involving the base of the appendix, or if it is involving the tip of the appendix. If it is involving the base of the appendix, I will see whether it is involving the cecal wall or not. We'll see whether the cecal wall is involved or if the cecum wall is spared. If the cecum wall is involved, then we have to go ahead with right hemicolectomy. If the cecal wall is not involved, then you can do an appendicectomy. And you have to bury the appendicular stump. Bury the appendicular stump with purse string suture. If it is just involving the tip, then perform an appendicectomy. If it is just the tip, then you have to put appendicectomy. So this is if it is going to be in terms of complication. The last one that you get is going to be your appendicular mass. Now, if a patient presents to you with appendicular mass, then you have to follow something called as the Ochsner-Scherin's regime. For appendicular mass, we are going to follow something called as the Ochsner-Scherin regime. Your Ochsner-Scherin regime. Now, what does this Ochsner-Scherin regime basically tells you? That first mark, you have to measure, no? So, mark the appendicular mass. See the size and just mark it. Second, start the patient, let's keep the patient on Nelparol, start the patient on IV fluids, give IV analgesia and then give IV antibiotics. Keep the patient Nirpa oral, start the patient on IV fluids, give IV analgesia as well as IV antibiotics and monitor vitals. Usually they respond. Once they respond, discharge the patient. Ask the patient to come back after 4 to 6 weeks for interval appendicectomy. For an interval appendicectomy, right? So this is how you have to give your answer for your acute appendicitis management. Now, if you put this table, no, the management table, your examiner is going to be super impressed, because you know you have covered everything from a simple appendix to a complicated appendicitis to that of an appendicular mass. You know the management of all three of the components. So whenever asked, you can put your answer in that precise manner, right? I hope everybody is clear. Clear? Okay. So that is the first 10 mark question that we have covered. That is your acute appendicitis. That is done. Okay. Chalo, let's go down to rectal cancer. So the next question that we'll be covering is going to be about the rectal cancer. Now, in fact, when you talk about the entire GI malignancies in terms of colorectum, you will see that around 38% of the total malignancies that are going to be present are going to be arising from the rectum itself, right? So rectum is overall the most common site for the large bowel malignancies. Okay? So when you talk about any cancers, you should first know the risk factors. So I'll be addressing the risk factors for the rectal cancer. So we'll talk about the risk factors associated with that of the rectal cancer. Now, in the risk factors, the most important risk factor is going to be high fat intake. High fat intake with low fiber diet. High fat intake with low fiber diet. Then you have the genetic components. The genetic components are example like familial adenomatous polyposis, Gardner syndrome, Turcot syndrome, Lynch syndrome. Your Lynch is nothing but HNPCs, that is hereditary non-polyposis colorectal cancer. So FOP, Gardner syndrome, Turcot syndrome, Lynch syndrome are the genetic components that you have to remember. It is also associated with inflammatory bowel disease. Also associated with the inflammatory bowel disease. Earlier we used to say that Crohn's disease has a higher incidence when compared to ulcerative colitis. Now ulcerative colitis and the Crohn's disease have the equal incidence. It has got an equal incidence of development of the rectal cancer. When you talk about in the entire context, I can say ulcerative colitis is slightly higher, because in Crohn's usually we see rectal sparing. So whereas ulcerative colitis, rectum is the most common site. So if you ever want to pick it up as one single answer, then I would say ulcerative colitis is slightly more common when compared to Crohn's disease. Otherwise, they both exist in the same component. Okay? So this is in the context of inflammatory bowel disease. Then it is also associated with polyps. Remember, the maximum risk is associated with the adenomatous polyps. It is associated with the adenomatous polyps and the history of pelvic radiation. And the history of pelvic radiation. And the history of the pelvic radiation. Now, when you talk about the rectal cancers, so let's talk about the clinical presentation. So talk about the clinical features of the rectal cancer. Now, to understand the clinical features, just for the sake of understanding, if you take this as a representation of the ascending colon, this is the ascending colon, this happens to be the hepatic flexure, this happens to be the transverse colon, this is the splenic flexure, this happens to be the descending colon, this is the sigmoid colon, and from here you will see your rectum is going to start. this is the rectum and this happens to be the anal canal, right? So in the sake of understanding, rectum comprises on the left side. So when you talk about the colon cancer, the left-sided components are going to be quite different. So this is where we say the junction between the sigmoid colon and the rectum, and this is the junction where you have the rectum and the anorectal junction, right? So this is your sigmoid and the rectal junction. This is your anal canal and the rectum. This is your anorectal junction, right? So this is what we call it as the anorectal junction. So usually when the tumor is going to arise, it is going to arise in the rectum somewhere across here, right? Now what are the clinical features? Now as it starts to develop, and that too on the, if you look at the colon, this is the right side of the colon, this is left. So it's going to be in the left-sided features, right? Now how would they present to you? Now most of these tumors, they are vascular, right? So because they are vascular, they're going to bleed and they're also going to cause obstruction. So the first thing the patient will experience in the rectal cancers, the patient will have constipation. There's a constipation relieved with diarrhea. So what happens is all that stools which are going to be present, they will come and they get blocked here because there is a mass or growth here. So patient will not be able to defecate. So hence there is a constipated feeling. Because it's a tumor, the tumor has the ability to secrete. So there's a lot of secretion that are going to be present from the tumor, and that secretion will be liquidative. And that in general will liquidate the entire component of the stools. And now the patient will present to you with diarrhea. So there is obstruction due to the mass that results in constipation, but there is a fluid that is going to secrete, or a lot of secretions from the tumor will liquidate the stools, and the patient will pass a liquid stools. Now this is usually on the early morning and is rich in all the secretions. So there will be presence of an early morning spurious diarrhea. And obviously because of this, the patient will have multiple defecations, again different timings. So there is alteration. There is alteration in bowel habits. There is alteration in bowel habits. Patient will also have a lower GI bleed, and here it will be more of hematochezia. Now hematochezia is a fresh blood in stools when compared to melena, which is old blood in stools, right? So your hematochezia indicates it's probably a rectal or an anal canal disorder. Your melena indicates the distal part, that is from the sigmoid colon or the ascending or descending colon. So there you have the hematochezia as well as melena. They'll also be associated with significant weight loss. They'll be associated with significant weight loss. Remember the most common route of spread. The most common route of spread for the entire GI or the colorectal malignancies is hematogenous, that is blood, and the most common site for metastasis. The most common site for secondaries or metastasis is usually liver, because the entire GI system is drained by your portal system, and that portal system goes and opens into the liver. So hence patient is going to have liver secondaries. The patient is going to have liver secondaries. Now obviously patient has presented lower GI bleed. So what are the investigations that we are going to conduct? Now in terms of investigation, the first one is going to be a DRE, that is your digital rectal examination. That is going to be a DRE, that is your digital rectal examination. Now after the digital rectal examination, you might feel there is something, so go ahead with colonoscopy. Now obviously when you see a mass which is present in colonoscopy, you have to get a biopsy done. You'll also get a CECT of the abdomen to look for the extent of the tumor. And to confirm, once it is confirmed as malignancy, to know the staging, you have to go ahead with PET CT. The PET CT is for the staging of the cancer. Now there is a staging that we all should be aware of, that is called as the Duke's staging. Now according to the Duke's staging, there are different components that you should be aware of, right? So when you say Duke's staging of the colorectal cancer, they are organized in an alphabetical order, right? So we have Duke stage A, which is tumor limited to mucosa and submucosa. Tumor limited to mucosa and submucosa. B is tumor between submucosa and serosa. That's a B1. Then you have B2 is tumor beyond serosa. It is a tumor beyond serosa. Then C1 is B1 with involvement of regional lymph nodes. C2 is B2 with involvement of regional lymph nodes. D stands for distant metastasis. D stands for distant metastasis. Clear? Now, once you have concluded the Duke staging, let's talk about the management of the rectal cancer. Now, in terms of management of the rectal cancer, we need to follow something called as the margin of resection. Now, what is the margin of resection that you will follow in rectal cancers? So there are two margins that you have to obey. One is your proximal margin, another one is your distal margin. So one, there is a proximal margin, another one is a distal margin. The proximal margin is going to be 5 centimeters and a distal margin is going to be 2 centimeters from the tumor to achieve an adequate resection. Now, what do you mean by this? So for this, you have to depict that this is the sigmoid colon. Let's say this happens to be the sigmoid colon, this happens to be the Teniae Coli, to tell you that this is where the sigmoid colon ends and this is where the rectum is going to start. So when you take this as a representation of rectum, this happens to be your anal canal, right? Now, if you look at the whole orientation, on the posterior aspect, you have the vertebra that is present. So I'm just depicting this as the vertebra. On the anterior aspect, you have the pubic bone. So I'll just say this is your pubic symphysis, right? There is a muscle that is present here, which is like a sling muscle attached on both ends, and this is what we call it as the puborectalis. Now there's a muscle that is present at the anorectal junction, and the muscle that is present at the anorectal junction is what we call it as puborectalis. It's an extension of the levator ani muscle, which is actually a pelvic floor. So why this is important? This muscle actually maintains the continence, right? So this anorectal angle, no, that is, so if you have to imagine it, imagine that this muscle pulls this anorectal junction towards the pelvis. So obviously this is going to get compressed. Now because it remains compressed, it gives the strength to the anal canal to hold the stools and not allow it to pass. So this is one of the most important, or the most, I would say, overall the most component mechanism to maintain the continence, right? But this, if I had to explain Teniae Coli, then it's going to get difficult. It's a band of tissue that is present over the large bowel, which divides them into these compartments which are called as hastrations. So this is what your Teniae Coli is. Okay. Chalo. Now you will see a lot of fat is going to be present along the rectum. There's a lot of fat that is present along the rectum. Now this fat is very important from a surgical standpoint, because all the lymph nodes which are present, no, all the lymph nodes are present or embedded inside this fat. right? So the lymphatic drainage of the rectum is in this perirectal fat that is going to be present. Now, why this becomes very important for us is, you need to understand that the whole concept of the oncology depends upon the adequate resection that you can bring across. Okay? You will see there is a peritoneal reflection that is going to be covering the sigmoid colon, and this reflection is what we call it as the serosa. So serosa is actually a fancy word. Serosa is nothing but the parietal peritoneum. It is nothing but your visceral peritoneum, right? This is the serosal surface, which is called as the visceral peritoneum. You will now notice that this is going to only cover the upper 1/3 of the rectum. From there is no peritoneal cover, there is no serosa. So rectum per se does not have any serosa, right? This arches out, there's a bladder here, and obviously in female there will be uterus and all, but this is where the arch is there, nothing else is going to be present. Okay? One second. Right. In front of the vertebra, there is this prevertebral fascia, right? So you see this, which we have seen here. It is your prevertebral fascia. This is your prevertebral fascia. On the rectum, you will see there is this layer that is present. We have a layer over the rectum, and that is called as the investing fascia of the rectum. So you'll see this is the layer that is present, and this is what we call it as the investing fascia of the rectum. There is this investing fascia. There is the investing fascia of rectum, which is here, right? Now there is a fascia that is connecting the prevertebral fascia and the investing fascia of the rectum, and this fascia is what we call it as. There is a fascia that is going to cover these two things. There is prevertebral fascia connecting to that the investing fascia of the rectum, and this is what we call it as the Valdeas fascia, also called as the rectosacral fascia. This rectosacral fascia is what we called as the Valdeas fascia. On anteriorly, you will see that this same thickening is going to cover the prostate as well as the rectum. It divides the prostate anteriorly and the bladder there, and this is what we call as the Denon-Vellus fascia. It is your Denon-Vellus fascia. This is your Denon-Vellus fascia. Now, why it is important is when you are removing the rectum, you have to remove with its fat. Now, when you remove with its fat, the concept is what we call it as TME, that is total mesorectal excision. If you don't remove the mesorectum, that mesorectum is nothing but the fatty component, you have done an inadequate dissection. The recurrence of the malignancy will occur. Now, if I give you an easier version of the management protocol, let's say this is where the rectum is going to start, and let's say this is where the anal canal is going to end, and this is your anorectal junction, and this is your perianal skin. Normally we say that if this is the tumor that is present, we have to obey the margin of resection. So we have the proximal margin. This is what we call as the proximal margin. The proximal margin of the resection. This proximal margin, we never have a problem with proximal margin because it is quite adequate. The problem always lies with the distal margin, because the minimum distal margin that you should have, the minimum distal margin that you should have in the rectal cancers is going to be 2 centimeters. So once you have resected it, I'm going to measure from the lower margin, that is from the distal margin's lower end, to that of the anal verge. Now, anal verge is a junction between the anal mucosa and the skin. This decides. So this is the distance between the lower margin, and anal verge. And the anal verge, we will measure this distance. Now, if this distance is more than 5 centimeters, then you can go ahead with resection and anastomosis. you can go ahead with resection and anastomosis. But if this distance is less than 5 centimeters, then we will prefer something called as APR, that is abdominoperineal resection. And APR is your abdominoperineal resection. Now, APR and abdominoperineal resection is basically a surgery where you're giving a patient with permanent colostomy. There is this permanent colostomy that you're creating. So here the anal opening will be closed because you've removed the entire anal canal. There will be descending colon will be opened onto the left side of the abdomen, remaining as colostomy for the rest of his life. And this is what we call as APR. We'll also give the chemotherapy to these patients, and the chemo regime that we follow is of FOLFOX, or you can also give the Folfovir. Now in FOLFOX, FOL stands for folinic acid. Another F stands for 5-fluorouracil, and OX stands for oxaliplatin. Another one here also, FOL stands for folinic acid. Another F stands for 5-fluorouracil, and then you have the irinotecan. Then you have the irinotecan, right? So these are the chemo regimes that you have to follow with rectal cancer. So this is how you will manage your patients of rectal carcinoma. Clear? So finished our second 10 marks question, that is your rectal cancers. So talking about the hemorrhoids and the fistula-in-ano, I'll cover both of them in a single subset. So talk about hemorrhoids. So the next answer that we're talking about is going to be about the hemorrhoids. Now, hemorrhoids are classically defined as dilated. They are dilated, distended, submucosal anal cushions. So these are nothing but the veins which are draining the submucosal segment. So these are dilated, distended submucosal anal cushions is what we call it as the hemorrhoids, right? Now, when you talk about the hemorrhoids, what are the risk factors? One of the major risk factors for the hemorrhoids are considered to be constipation. It is secondary to constipation, passing hard stools. The secondary to passing hard stools. It can also be seen secondary to portal hypertension. It is seen in connective tissue disorders. It is seen in the connective tissue disorder. So there is this constipation, passing hard stools, portal hypertension, connective tissue disorders, secondary to pregnancy, and rectal malignancy. These are the usual risk factors for the development of hemorrhoids. Now, we classify the hemorrhoids based upon their presentation. So we simply go ahead with hemorrhoids classification. So when we talk about the hemorrhoids classification, it is based upon their location and based upon their origin. So one subset of hemorrhoids, we classify them into internal and the external hemorrhoids. So we have the internal hemorrhoids and then you have the external hemorrhoids. One we have the internal hemorrhoids, another one we have the external hemorrhoids. Another subset of classification that you can see it will be seen as primary hemorrhoids and the secondary hemorrhoids. So one you have the primary hemorrhoids, another one is the secondary hemorrhoids. So what is the internal external hemorrhoids? It's quite simple. You take this as the representation of the anal canal, and this is your dentate line that is present, and let's say this is the rectum, which is going to be above this. So this is the rectum, and then it continues into anal canal, and this is your anal verge, and this happens to be your anal mucosa. Any hemorrhoid that is present above the dentate line is what we call as internal. Below the dentate line is what we call as the external hemorrhoids. So these are considered to be as internal hemorrhoids, and these are considered to be as external hemorrhoids. So external hemorrhoids are below dentate line. They are present below the dentate line. Internal hemorrhoids are the hemorrhoids that are present above the dentate line. So internal hemorrhoids are present above the dentate line, external hemorrhoids are present below the dentate line. Then comes the primary and the secondary hemorrhoids based upon their venous drainage. So you take the cross section of the rectum. This is the rectal mucosa. The cross section of the rectum, and this happens to be the rectal mucosa. Now when you point it as a clock, you will notice that this is 12 o'clock, this is 6 o'clock, this is 3 o'clock, this is 9 o'clock. So this is 12, 3, 6 and 9. Same here. 12, 3, 6 and 9. 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. Now if the hemorrhoid arises from 3 o'clock, if it is arising from a 7 o'clock, or it is arising from 11 o'clock, it is called as a primary hemorrhoid. Anywhere else than that, if it is arising from 12 or from here, if it is arising from a 6 o'clock or a 9 o'clock, it is considered to be a secondary hemorrhoids. So hemorrhoids arising, if it arises from 3, 7 or 11 o'clock, that is primary hemorrhoids. If it arises anywhere else, if it arises anywhere else than 3, 7 and 11. If it arises anywhere else than 3, 7, 11, it is called as your secondary hemorrhoids. So this is the classification of hemorrhoids between internal, external, primary as well as secondary hemorrhoids, right? Usually when we talk about the clinical presentation of the hemorrhoids, the clinical features of the hemorrhoids is going to present to us bleeding per rectum. They usually present to you with bleeding per rectum. That's a usual presentation. Now because they're presented with bleeding per rectum, I would like to investigate in terms of investigation. Obviously I will go ahead with digital rectal examination, but more importantly I will go ahead with proctoscopy. Now based upon the proctoscopy, we have different grades of hemorrhoids that we have. So the grades of hemorrhoid is on the basis of bleeding that is going to be present, and is the hemorrhoid protruding or not, that is protrusion. In grade 1 hemorrhoid, there is presence of bleeding, there is no protrusion of the hemorrhoid. Grade 2 hemorrhoids, they will see the presence of bleeding, the presence of protrusion, but it spontaneously reduces. It spontaneously reduces. Then you have grade 3 where there is presence of bleeding, presence of protrusion, but here it is manually reduced. Here it is manually reduced. Then it is grade 4 hemorrhoids where there is presence of bleeding, protrusion is present, but this time it cannot be reduced manually, it is prolapsed. This is usually prolapsed, right? So these are the grades of hemorrhoids that you should be aware of. How would you like to manage? In terms of management of hemorrhoids, it is a grade wise management that you have. So grade 1, grade 2, grade 3 and grade 4. So for grade 1 hemorrhoids, it is going to be a conservative management. Now in the conservative management, number 1, we'll try to give the patient a soft diet. Make these two softer, so I'll give laxatives. I'll ask the patient to take sitz bath and adequate hydration. So give soft diet, laxatives, sitz bath, adequate hydration and increased fiber diet. Grade 2 hemorrhoids, we can try conservative. We can try a conservative management. If this fails, then you can go ahead with banding or you can go ahead with sclerotherapy. Grade 3, we usually go ahead directly with banding. If it fails, then you go with surgery. Grade 4, we will prefer surgery alone. So when you talk about the surgery, what are the surgeries that you have? Number 1, you can have the Milligan-Morgan surgery. Then you have the Ferguson surgery. The difference is Milligan-Morgan, you excise the hemorrhoid and leave the mucosal segment open. Whereas in Ferguson's, you suture it back. The third one that you have, that is after Milligan-Morgan, when you have done the Ferguson surgery, third one that you have, your stapler hemorrhoidopexy. It is usual circular stapler. So Milligan-Morgan surgery, Ferguson surgery and stapler hemorrhoidopexy can be performed in your hemorrhoidectomy, right? So these are with respect to management of the hemorrhoids. Okay. So we finished our third question as well, and that is going to be our hemorrhoids. The last question that you should be knowing is your fistula-in-ano. So let's go to fistula-in-ano. So talk about the fistula-in-ano. The fistula-in-ano is described as an abnormal communication. It is an abnormal communication between anal mucosa and perianal skin. So it's an abnormal communication between the anal mucosa and the perianal skin is what we call it as the fistula-in-ano, right? Now let's understand what is the underlying cause. What is the underlying cause for the fistula-in-ano? The underlying cause for the fistula-in-ano can be divided into primary cause and the secondary cause. So look at the primary cause and we look at the secondary cause. So when we say the primary cause, there are two important primary causes. Number 1, if there is a spontaneous rupture of perianal abscess. The spontaneous rupture of perianal abscess, or if there is an inadequate drainage of perianal abscess. One, there is a spontaneous rupture of the perianal abscess. Second, there is an inadequate drainage. Is there an inadequate drainage of the perianal abscess? So can you explain what is fissure? But a fissure is actually a longitudinal ulcer at the anal verge due to passing hard stools, or it is because of repeated strenuous frictional irritation of the anal mucosa. Now, we talk about the secondary causes. The secondary causes for the perianal fistula or the Fistula-in-ano, it can be secondary to Crohn's disease. It can be secondary to tuberculosis. It can be secondary to radiation proctitis. Crohn's disease, tuberculosis, radiation. It can also be secondary to actinomycosis. So Crohn's, TB, radiation and actinomycosis are the secondary causes for Fistula-in-ano. Okay. Now, based upon where the opening starts and where does it end, we have a classification for the Fistula-in-ano, and that is what we call it as the Parkes classification. We have the Parkes classification of the Fistula-in-ano. Now, according to the Parkes classification, let's understand this. Now, if you take this as the representation of the rectum, and let's say this is the anal canal that we have, right? This is the perianal skin, which is going to be present here. So just representing it here. Now, there are two sphincters which are going to be present. I hope everybody knows it. The first one is what we call it as the internal anal sphincter. The internal anal sphincter is actually an extension of the circular muscles. So when the circular muscles of the anal canal, they hypertrophize and they form the internal anal sphincter. So the internal anal sphincter is actually a smooth muscle. Then you see on the outer surface, you have the external anal sphincter. So this is your external anal sphincter. Now the external anal sphincter is actually a continuation of your pelvic floor muscles. So it's a skeletal in origin. So this is your external anal sphincter. So you see this is the external. So this is your external anal sphincter. So this is the integration of your internal anal sphincter. And this happens to be the integration of your external anal sphincter, right? For the sake of understanding, I'm just going to mark it down. So this is your internal anal sphincter, which is here. This is your external anal sphincter. At this junction, we know there is a muscle that is present, and that muscle is going to be your puborectalis. This muscle that is present is your puborectalis, right? Now, where does it open? Where does it end? All these is important components. So this is your internal anal sphincter that we have, and the external anal sphincter. Now you'll notice if the inner opening is in the, see, there has to be two openings to call it as a fistula. One has to be inside the anal mucosa, one has to be on the skin. So if there is one opening here, another opening here, and you see the tract is going to be in this manner. So you can see it is piercing the internal anal sphincter, traveling between the internal and the external anal sphincter, opening into your cutaneous. This is your intersphincteric variety. Another one, there's internal opening here, the external opening here. You can see the tract piercing both the internal and the external anal sphincter. This is what we call as transsphincteric. The internal opening is here, the external opening is here. The tract which is going to be present, it is going to actually travel. The tract travels above the puborectalis and then opens. This is called as suprasphincteric. If the opening is in the rectum, bypassing the entire sphincter apparatus and then opens on here, this is what we call it as extrasphincteric, right? So according to the Parkes classification, the 4 varieties of Fistula-in-ano that you see. Now the first variety that we have mentioned here is what we call it as the intersphincteric variety. It is the intersphincteric type. The type 2, it is piercing both. It is your transsphincteric variety. It is your transsphincteric variety. Type 3 is going to be suprasphincteric. it is your suprasphincteric type, and your type 4 okay, the type 4 is what we call it as extrasphincteric type. So type 1 is the first one is intersphincteric, then you have the transsphincteric, then you have the suprasphincteric, and then you have the extrasphincteric variety. So all these are considered to be as the different forms of the fistula-in-ano. It is your fistula-in-ano, right? Now, how does the patient present to you? We talk about the clinical features. Now, clinical features of the fistula-in-ano. The first thing that the patient usually complains or will say is there is a foul smelling. There's a foul smelling perianal discharge. Now that foul smelling perianal discharge is nothing but stools that have traveled from the fistulous tract and getting accumulated. There is presence of cutaneous. There is presence of the cutaneous ulceration. There is presence of cutaneous ulceration around anal verge. There's a cutaneous ulceration around the anal verge that is present. Along with the cutaneous ulceration, you'll also need, there'll be fecal soiling. There'll be fecal soiling of undergarments. So there'll be a foul smelling perianal discharge will be present. There'll be a cutaneous ulceration around the anal verge is noticed. There'll be fecal soiling of the clothes are addressed. There is fecal soiling. There'll be fecal soiling of the undergarments is noticed. Along with that, patient will give you a history, probable history of perianal abscess. Now, whenever you have a presentation like this, the investigation that you would do, number one, we will do a digital rectal examination. Number two, I'll do a proctoscopy to see any opening is visible. Then I would like to go ahead with the MR fistulogram. For complex varieties, you can also plan for endoanal ultrasound. So digital rectal examination, proctoscopy, MR fistulogram, and the endoanal ultrasound is what you have to do for your fistulas-in-ano, right? So once you have diagnosed in your patients with fistula-in-ano, the management depends upon what type of the fistula that you have. Is it the type 1 variety or the type 2 variety, or do you have the type 3 or a type 4 variety? For a type 1 or type 2 variety, you can go ahead with fistulotomy to open up the tract. You can also go ahead with fistulectomy. So you have the fistulotomy, you can go ahead with fistulectomy. Also, you can go ahead with laser. You have the laser fistula tract closure. Or you can also go ahead with fibrin glue injection. These are the other options for closing the fistulous tract. Rishabh, you're talking about the tags, no? They're called as sentinel pile. Sentinel piles are a feature of fissure-in-ano, not fistula-in-ano. Okay? Sentinel pile alag hai, pile alag hai. Pile is called as hemorrhoids. Sentinel pile is called as skin tags. Skin tags are seen in fissure-in-ano. So then you have type 3 and type 4 ke liye, you will go ahead with sit-on. It's a sit-on placement, which is usually a cutting sit-on. So the basic concept of this cutting sit-on is, if you have, this is the perianal skin that you have, and there is the opening of the tract is here, opening of the tract is here, and the tract is going like this. Now because it is going through the internal anal sphincter, it is going through the external anal sphincter. Now if I go and try to operate, I will cause more damage to the sphincters. So see, if the sphincter's mechanism is lost, the patient will have incontinence. I cannot have a patient develop an incontinence. So what we do is, we take a thread, right? It's like a cutting thread that you have. I will insert the thread into the tract and I will pull it out from here, right? So this thread has traveled through inside. Now what I'm going to do is I'm going to tie these two threads, right? Now imagine it this way. Okay. So what you're going to do is, now I've tied this thread and I'll continue to tighten it. Now as I tighten, because it's a cutting thread, now as I tighten, it will cut through, and then it will open up the tract, but lower end will continue to fibrose. In that way you prevent the incontinence, and this is what you do in the context of cutting sit-on. Okay. So this is all that you should know in terms of fistula-in-ano. So what are the questions that they've asked you in hernia? The questions that they've asked you in hernia is, number one, a short note on inguinal hernia. They've asked you about the inguinal hernia. They asked you about, see, there's a collective set of questions where they asked you complications associated with inguinal hernia. Complications in hernia and its management. So they've asked you about inguinal hernia. They've asked you about the complications which are associated with the hernia and its management. Then they've asked you how to differentiate between indirect inguinal hernia and the direct inguinal hernia. They asked you how to differentiate between indirect inguinal hernia as well as direct inguinal hernia, right? So can you please later make an orientation class for upcoming 4th year? Sure, beta Nebula will do that. So don't worry about it, right? So these were the questions which are asked. We'll try to summarize them. A short note was for 5 marks. Complication was 5 marks. And there was this 5 marks. And there was one question where a combination of these two were given. That is difference, and then this was of 10 marks, right? So we'll try to give you a wholesome approach that if a question comes, how are you going to write accordingly? Clear? Right. So let's dig in with respect to the first one, that is going to be inguinal hernia, right? So we'll talk about the answer. So here the answer we are going to focus is going to be on inguinal hernia. Now in the inguinal hernia, so whenever you talk about any hernias, whenever you talk about any hernias, you need to know the basic definition of hernia, and then you move accordingly as we say across. So what is defined hernia? Hernia is defined as, it is the protrusion of abdominal viscera. Protrusion of abdominal viscera through an abdominal wall weakness. Through an abdominal wall weakness. Through an abdominal wall weakness is what we define as hernia. It's a simple definition of hernia. It is the protrusion of abdominal wall viscera through an abdominal wall weakness is what we call it as hernia, right? Now, here's an important thing that when you talk about inguinal hernias, you should know a quick recap on the anatomy of the inguinal canal. So the next heading is going to be inguinal canal anatomy. So I'll tell you the easiest way to draw the inguinal canal and then represent it at the same time. In the inguinal canal anatomy, you need to understand the following components, right? So on the medial most aspect, you can draw a line which says this is the rectus abdominis wall muscle, right? So this is your rectus abdominis wall muscle, right? Now just undersurface it, this is your pubic arch, this happens to be your pubic tubercle, this is your pubic symphysis, and this is your pubic bone that is going to be present across here, right? So this is the orientation of the pubic bone. Now this is going to help me. I'll just take a little bit, change the rectus abdominis muscle. So should okay, I should have given the pubic bone first and then gone for it. Anyhow, so this happens to be your rectus abdominis wall muscle, which is right in the middle, and this is your pubic tubercle, which is going to be present, right? Now on the medial side, you see there is rectus abdominis wall muscle, right? Now look at the outermost part. The outermost part is going to be your external oblique muscle. So this external oblique muscle is going to come and it is going to attach. So this is your external oblique muscle, which is going to be present. Now as it nears the abdominal wall, it is now going to convert into aponeurotic tissue. So this is your aponeurosis, right? So this is all your aponeurosis, which is going to form here. Now this aponeurosis, as it comes closer to the inguinal canal, it condenses itself and forms an inguinal ligament, and that inguinal ligament is going to attach from the anterior superior iliac spine to the pubic tubercle, right? So this is your pubic symphysis, and you can see this is your external oblique aponeurosis, right? Now when you look at this external oblique aponeurosis, as it comes across here, the external oblique aponeurosis in this particular site, external oblique aponeurosis in this particular site, it is going to turn backwards like this, right? Now as it attaches and it is going to flip on itself, so it's like turning on itself, right? It is going to rotate on itself. Now as it rotates on itself, it forms a small opening, and this opening is what we call it as the superficial inguinal ring. This is what we call it as the superficial inguinal ring. Now if they ask you what is a superficial inguinal ring, the superficial inguinal ring is basically a small defect that is going to be present on the external oblique aponeurosis. For the sake of understanding, those who have just joined, the first muscle that I've drawn in front of you, this is your external oblique muscle. This is going to be your external oblique muscle that is present. This is your external oblique aponeurosis. Behind the external oblique muscle, you have another muscle which is going to be the internal oblique muscle. Behind the internal oblique muscle, you have the transverse abdominis muscle, and behind the transverse abdominis muscle, you have the fascia transversalis. Behind this, you have the fascia transversalis, which is going to be present throughout, right? So this is the fascia transversalis, which is the posterior most muscle that is present, and that fascia transversalis, as you go across, will cover the entire abdominal component. Now behind the fascia transversalis, what do you have? Behind the fascia transversalis, the last layer that is going to be present inside the abdominal wall, this is going to be your peritoneum. So if you look at the cross section, from top to bottom, this is your external oblique muscle. This happens to be your external oblique muscle. This happens to be your internal oblique muscle. This happens to be your transverse abdominis muscle. This happens to be your fascia transversalis, and the innermost is going to be peritoneum. The innermost is going to be peritoneum, right? So when you look at the whole context here, you have the external oblique muscle, the internal oblique muscle, the transverse abdominis, fascia transversalis, peritoneum, and inside the peritoneum, you have your abdominal cavity. Now, if you have understood this basic orientation, I will just isolate the components so that you understand better. Now the outermost surface, this is your inguinal canal, and I said it is going to flip on itself. Now as it turns on itself, it is now going to create an opening here, and this opening is what we call it as the superficial inguinal ring. Now this is the anterior surface. Posteriorly, what do you have? Posteriorly, you're going to have the fascia transversalis, and the defect in the fascia transversalis is what we call it as the deep inguinal ring. And beyond this, what do you have? You have the peritoneal surface. Now if you look at, this is just for the sake of orientation, if you're not able to get a grip, this is the anterior surface and this is the posterior surface, right? So in the anterior most, this is your external oblique aponeurosis. This is your external oblique. This happens to be your external oblique aponeurosis, right? So defect in the external oblique aponeurosis is what we call it as the superficial inguinal ring. Now the innermost that you can see here, this happens to be fascia transversalis. Now this fascia transversalis this fascia transversalis has a defect, and this defect is what we call it as the deep inguinal ring, and the innermost layer that you have is going to be peritoneum. Now this we all know, right? Now what is going to happen? You will notice that in the inguinal canal, if you take this as a representation of the testes, right? This is the representation of the testes. You will find that the vas deferens from the testes is going to arise. The vas deferens arises from the testes, enters into the superficial inguinal ring, travels into the inguinal canal, exits from the deep inguinal ring, turns medially, and then it goes. So what is the journey of the vas deferens? The vas deferens is going to go behind the bladder. It is going to combine with the seminal vesicles. Together they form the ejaculatory duct. They go into the prostate. In the prostatic urethra they open, and the opening of that structure is what we call it as verumontanum, right? यही journey है. तो पूरी journey कहाँ शुरू? टेस्टिस से शुरू हुई, vas deferens की, inguinal canal, superficial inguinal ring में enter किया, inguinal canal में गया, deep inguinal ring से निकला, एकदम U-turn मारा. जैसे ही U-turn मारा, it is now going to go behind the bladder. It travels between the peritoneum and the fascia transversalis, goes behind the bladder, combines with the seminal vesicle, forms an ejaculatory duct, opens into the prostatic urethra guarded by, or that opening is known as verumontanum. इसके साथ you will see there's another nerve that is going to be present. The nerve that is going to travel in the inguinal canal along with the vas deferens. This is going to be your ileo-inguinal nerve. So two structures. This is going to be vas deferens. This is going to be vas deferens, and this happens to be your ileo-inguinal nerve. This is going to be your ileo-inguinal nerve, right? So these are the important structural component that you need to know. Is that clear? Right? So this is the anterior orientation of your abdominal wall, and this condensation that you see at the bottom, no, this is what we call it as the inguinal ligament. This is what we call it as the inguinal ligament. This is what we call it as the inguinal ligament, right? Now the attachment of the inguinal ligament is going to be from the anterior superior iliac spine, which is called as ASIS, and this attachment here is going to be with pubic tubercle. This attachment is going to be pubic tubercle. Sorted? Okay. So this is your first orientation that you need to keep with respect to the anatomy of the inguinal canal. So if they are going to ask you define the anatomy of the inguinal canal, I hope nobody is going to go wrong now. So if they ask you the anatomy of the inguinal canal, so this is how the anatomy of the inguinal canal will be described. Clear? Right? Now, once you have described the inguinal canal, couple of important points that you can tell, and in fact you can write it down, that the superficial inguinal ring, just for the sake of completion, the superficial inguinal ring is going to be triangular in shape, whereas deep inguinal ring is inverted U-shaped. Going to be inverted U-shaped. So deep inguinal ring is a defect in fascia transversalis. Superficial inguinal ring is actually a defect in external oblique aponeurosis, right? Metoprolol will tell you which surgery causes the damage of ileo-inguinal nerve. It is the open inguinal hernia repair. Okay, so don't worry. So this is about inguinal canal anatomy. Now another question that they asked you is comparison between the direct inguinal hernia and the indirect inguinal hernia. So we'll quickly talk about how would you compare between indirect inguinal hernia, indirect inguinal hernia. We'll have a comparison between indirect inguinal hernia versus direct inguinal hernia. Indirect inguinal hernia versus the direct inguinal hernia, right? So in the comparison, the first thing you need to know is the basic representation that we already did. We'll follow the same diagrammatic representation so that we don't goof up. Now, what is the representation that you have? You have the external oblique aponeurosis. This happens to be superficial inguinal ring. Now, in deep inside, you have, this is your fascia transversalis. This is your deep inguinal ring. This continues across here, right? Now, next you have your peritoneum. The peritoneum is going to be present here. So this is the peritoneal surface that you have, right? So this we all know. There is a structure that is going to travel So I think we have used, okay, this is the color code. Now this is the vas difference which is going to go in the inguinal canal and is going to enter from here. And this happens to be the ileo-inguinal nerve, right? This has been our representation. We'll follow the same representation, right? So we'll not miss on this. So I'll just replicate it here so that we don't need to draw. Okay? So this is the comparison between the direct and the indirect inguinal hernia. So we'll quickly give you the basic differentiation. Now the first thing, you need to understand what are the entry points. So where does the entry point, where is the entry of the indirect inguinal hernia and direct? Where is the exit of this? What is the sac made up of? What is the sac made up of? What is the content of the hernia that you're looking at, and the relation? Relation to the surrounding is what you're going to look at, right? Now, in simple words, when you talk about indirect inguinal hernia, just to get the concept correct, indirect inguinal hernia, it so happens that you'll start exerting pressure. Let's say there's a bowel that is present, and that bowel is exerting pressure at the deep inguinal ring. Now, as the pressure continues to mount, what is going to happen? You will notice that this area is going to get widened. Now, under the influence of so much pressure that has been exerted, with so much pressure which has been exerted, you see the deep inguinal ring is going to dilate. Now, this dilatation of the deep inguinal ring is under the influence. It is under the influence of the pressure exerted by the bowel that is present here. So it will push the peritoneum here. So the peritoneum which is present here is now forced to go inside. Now, why is it forced to go inside? It all occurs because the bowel that is present here is exerting pressure. So the intra-abdominal bowel that is present, that is exerting pressure there. Now, as the pressure continues to mount, what will happen? This peritoneum will travel via the inguinal canal. As it travels via the inguinal canal, it is now going to pop out, and this popping is what we call it as the hernia, that is sac. So why it is going to pop? Again, this content which is present. Now this content which is present here is going to travel along with the inguinal canal. It is going to travel along with the inguinal canal. It will go through its entire journey. It is now going to exit through. It is now going to exit through, and this is how the indirect inguinal hernia is going to be formed. So in an indirect inguinal hernia, just for the sake of understanding, so that we all are on the same page, the green structure that we have drawn, this is the peritoneum. This is the peritoneum that is present, right? Now this pink structure that we have drawn, we'll say this is the bowel. This is the fascia transversalis. We'll say FT, that is your fascia transversalis. This is your external oblique aponeurosis. This is your external oblique aponeurosis which is forming. This is your deep inguinal ring. This happens to be your superficial inguinal ring. This is your superficial inguinal ring. This is your vas deferens. This is your ileo-inguinal nerve, right? So this is how your indirect inguinal hernia is going to be formed. Clear? Now for a direct inguinal hernia, there is a defect that is going to be present, or I can say abdominal wall weakness. When you look at, this is the medial side, no? There's a muscle which is present here. This is your rectus abdominis wall muscle, right? So the muscle which is here, this is your rectus abdominis wall muscle. Now from the external iliac, there is a blood vessel that is going to originate, and that blood vessel that is originating from the external iliac, this is your inferior epigastric artery. This is your inferior epigastric artery which is going to run. Now you see there is this area between the inferior epigastric artery, the rectus abdominis muscle, and the inguinal canal. You see this area? This area is where it is not guarded by any muscle, and this is an anatomical weakness that is present. And this anatomical weakness is what we call it as the Hasselbalch's triangle. Right, so the boundaries of the Hasselbalch's triangle is also very important. So when you describe a direct inguinal hernia, you cannot describe a direct inguinal hernia without describing the Hasselbalch's triangle. So this shaded part is your Hasselbalch's triangle. So the anatomical weakness lies in the Hasselbalch's triangle. So you see this is the medial boundary. The medial boundary is formed by the lateral border. It is formed by the lateral border of rectus abdominis muscle. Then this is the lateral boundary. The lateral boundary is formed by the inferior epigastric artery, and the inferior boundary, this is the inferior boundary, it is formed by the inguinal canal. It is formed by the inguinal canal. Now this triangular area, which is not guarded by any of these muscles, forms an abdominal wall weakness. Now once there is a weakness that is present, the same thing is going to happen. The bowel is now going to come and sit at this area. Now as the bowel comes and sit across this area, it starts exerting pressure here. Now as the pressure continues to mount, what is going to happen? As the pressure continues to mount, you see this area is now going to get deformed. This area is now going to get deformed. Now how it is going to get deformed, let's see, right? So you will notice that as more and more amount of pressure is going to be exerted, see this pressure is in this Hasselbalch's region, right? So this whole area is now going to transform. Let's see how it is going to transform, right? Now the first thing you notice that as the pressure mounts, the peritoneum is going to go down. This area will also go down. That is your fascia transversalis. This is your superficial inguinal ring. It is going to get dilated. Now why it is getting dilated is, you see this fascia transversalis is now forced. The fascia transversalis is now forced to pop out from this region. Now this occurs because of the pressure exerted by the bowel on the peritoneal surface. So the peritoneum is also going to pop out through this. Now all this is happening because of the abdominal wall weakness, which is explored by the bowel that is present here. So you see the bowel that is present here is now going to go across here. It is exerting pressure. It could be bowel or omentum both, but just for the sake of easy explanation, I'm using the example as bowel. And you see the content moving inside and pushing the everything, right? The vas deferens is in its own position. The vas deferens is here. The ileo-inguinal ring, nerve is going to be here, which is going to be present across here. Now, if you see the difference between the indirect and the direct inguinal hernia, this is going to be quite clear in front of you. In the indirect inguinal hernia, it is entering from the deep inguinal ring. It is exiting from the superficial inguinal ring. Whereas in the direct inguinal hernia, it is entering from the Hasselbalch's triangle and exiting, and it is exiting from the superficial inguinal ring. Okay? So this is a small concept that many of us tend to forget, and we think, अरे इधर का उधर हो गया, इधर का उधर हो गया, हर्निया में ये है, डायरेक्ट और इनडायरेक्ट में क्या फर्क है, कुछ नहीं. बट डायरेक्ट खुद घुस रहा है. इट इज जस्ट कमिंग, इट इज नॉट गोइंग फ्रॉम एक जगह. देखो इनडायरेक्ट में क्या एंट्री कहीं है, एग्जिट कहीं है. यहाँ पे एंट्री एग्जिट एक ही जगह से मार रहा है, तो इट इज गोइंग टू बी डायरेक्ट इंगुइनल हर्निया. ठीक है. सो नाउ इफ द कॉन्सेप्ट इज क्लियर, आपको ये कंपैरेटिव टेबल डालना है. ठीक है. ये थोड़ा सा स्टिक डायग्राम बना देना और ये लेबल कर देना. वंस यू हैव लेबल्ड इट, ऑल दैट यू हैव टू डू इज एंट्री एग्जिट. अब आप खुद बता दोगे. ठीक है. So when I say entry and exit, let's analyze every single component that we have. Okay? Now, when I say where is the entry of the indirect inguinal hernia, the entry of the indirect inguinal hernia is going to be from the deep inguinal ring, whereas for the direct inguinal hernia, it is going to be from the Hasselbalch's triangle. Okay? So in some context, rather than saying Hasselbalch's triangle, you can also use the word the posterior wall of the inguinal canal. Exit दोनों का एक ही है. The exit is going to be from the superficial inguinal ring. Now this outer covering that is present, no, ये जो outermost covering that is present, this is what we call it as the sac of the hernia. sac के अंदर जो भी मिलेगा उसको आप content बोलते हो. This is what we call it as the content of the hernia. ठीक है. सेम यहाँ पे भी देखो, the outermost covering is what we call it as sac. sac के अंदर जो भी मिलेगा उसको आप content बोलोगे. ठीक है. This is the content of the hernia. Now when you look at the comparison between both of them, सवाल ये है कि sac किससे बना हुआ है, right? Now sac in the indirect inguinal hernia is made up of peritoneum. आप खुद देख लो, समझ में आ जाएगा. ठीक है. Whereas sac in a direct inguinal hernia is made up of fascia transversalis. It is made up of fascia transversalis, right? So sac, it is made up of fascia transversalis, right? So in your inguinal hernias comparison, the entry and the exit points are important, so you have worked it out. The sac, what it is formed, we now know it. What is the content? Based upon the content, now if the content is bowel, this will be called as enterocele. If the content is omentum, this will be called as omentocele. सेम विल बी हियर. अगर कंटेंट बवल होगा आप इसको एंटीरोसील बोलोगे. if the content is going to be omentum, you will call it as omentocele. Now, based upon other words, we have like other structures, we can modify the name. For example, if the content is Meckel's diverticulum, it will be called as Litter's hernia. If the content is appendix, it will be called as the Amiens hernia, right? If you have both direct and indirect from the same inguinal canal, it is called as Pantaloon's hernia. So all these are special forms, but two common things, bowel and omentum. Bowel is called as enterocele, omentum is called as omentocele. Now, we have to see the relationship, that means between the sac and the cord. Now, when you talk about the sac and the cord, this is the medial side and this happens to be the lateral side. अगर आप indirect inguinal hernia में ध्यान दोगे कि cord यहाँ पे है और sac इसके lateral side में, तो sac will be present on the lateral side of the cord in an indirect inguinal hernia. Now come to direct inguinal hernia. Direct inguinal hernia में cord यहाँ पे, sac is on the medial side, ठीक है? So this is the medial side and this happens to be the lateral side, ठीक है? तो यहाँ पे आप देख रहे हो sac is going to be, it is going to be medial to the cord, and this is what you need to remember, that in relationship, not the one that you are thinking, ये hernia का relationship है, Valentine's Day कल चला गया था, आज पढ़ाई में concentrate करेंगे. तो relationship we are talking about here, you say the sac lies, it is going to sac lies lateral to the cord. यहाँ relation में आप बोलोगे sac lies medial to the cord. It is called the medial to the cord. Now, थोड़ा सा और अगर वाइवा में आपको परेशान करना है तो आपके एंट्री पॉइंट को ना, एंट्री पॉइंट इज ऑल्सो रेफर्ड टू एज द नेक ऑफ द हर्निया. इट इज ऑल्सो कॉल्ड एज द नेक ऑफ द हर्निया. अब इसका रिलेशनशिप देख लो. नाउ रिमेंबर द नेक ऑफ द इनडायरेक्ट इंग्वाइनल हर्निया, नेक लाइज लैटरल टू इंफीरियर एपिगैस्ट्रिक आर्टरी. यहाँ पे नेक लाइज मीडियल टू इंफीरियर एपिगैस्ट्रिक आर्टरी, टू द इंफीरियर एपिगैस्ट्रिक आर्टरी, राइट? सो इट इज गोइंग टू लाई मीडियल टू दैट ऑफ इंफीरियर एपिगैस्ट्रिक आर्टरी. कहाँ पे आपकी इंफीरियर एपिगैस्ट्रिक आर्टरी? आप देख रहे हो कि इंफीरियर एपिगैस्ट्रिक आर्टरी हमारी यहाँ पे है. दिस इज आवर इंफीरियर एपिगैस्ट्रिक आर्टरी, ठीक है? तो अगर आप इंफीरियर एपिगैस्ट्रिक आर्टरी, यू नो वेयर इट इज. नाउ वी से दैट इंफीरियर एपिगैस्ट्रिक आर्टरी का मीडियल और लैटरल कौन सा हो जाएगा? दिस विल बिकम द मीडियल साइड एंड दिस विल बिकम द लैटरल साइड. तो मीडियल से एंट्री कौन ले रहा है? मीडियल से डायरेक्ट इंग्वाइनल हर्निया. इनडायरेक्ट तो यहाँ से आएगा ना, तो इनडायरेक्ट इंग्वाइनल हर्निया इज गोइंग टू बी लैटरल टू इंफीरियर एपिगैस्ट्रिक आर्टरी, एंड दैट इज हाउ योर स्मार्ट एस रेडियोलॉजिस्ट नो. दे आर गोइंग टू टेल वेदर इट इज अ indirect or a direct inguinal hernia. They will map the inferior epigastric artery, see the defect is medial or lateral. If the defect is medial, it is your direct inguinal hernia. If the defect is lateral, it is going to be indirect inguinal hernia. Simple. ठीक है? So this is the basic concept behind the comparison between the two hernias, that is direct as well as indirect inguinal hernia. If you put this diagram and if you write these 4 or 5 points, मजाल है कि examiner 1 mark भी काट ले आपके. ठीक है? It is not possible if you are precise with their. See, you have described the inguinal canal anatomy, you have described the sac anatomy, you have given the content, you have given the components, you have told all the complex, difficult structures that need to be analyzed, and that is right in front of you. Clear? ठीक है? Now, once you have the presentation, now we'll talk about the clinical features of inguinal hernia. So talk about the clinical features of the inguinal hernia. We'll talk about the clinical features of the inguinal hernia, right? So what are the clinical features of the inguinal hernia that you can think about, right? The first thing, how will the patient present to you? Now, the most common presentation would be of inguinoscrotal swelling. There will be presence of inguinoscrotal swelling. Now, these scrotal swellings are usually painless. They are usually painless, right? So the primary complaint that the patient is going to come to you, it is going to be an inguinoscrotal swelling. It is going to be painless, and patient says that it varies in size. It varies in size. That means sometimes it is big, sometimes it is small. Now, the minute you say it is varies in size, inguinoscrotal swelling, you know it is hernia, because hydrocele do not vary in size, right? Now, I would like to examine. So the next immediate thing is going to be on examination. So on examination, what are the findings? So the first thing you have to tell your examiner that you know how to examine a hernia case. Now, in which position, which I would like to examine. Now, commonly given wrong answer is they're going to be in a supine position. Remember, hernia should ideally be examined in a standing position. In a standing position, after reducing the hernia. After reducing the hernia. Now remember, hernias are usually reduced in a supine position. That's also an important thing. ठीक है, hernia का reduction जो है supine में होगा, लेकिन examination will be in a standing position. So on examination, what are the findings that I'm going to get? The first finding, I will see that as soon as I see that inguinal scrotal swelling, it is going to be a reducible swelling. That is, if I exert pressure, it is going to disappear. Now, based upon if it is going to be granular, I can say it is omentum. If it gives a gargling sound and there is some resistance to reduce, it is usually bubble. Okay. Now, it is going to be reducible swelling, number one. Number two, once you reduce it, you ask the patient to cough. And as soon as the patient coughs, the swelling will reappear. So, there will be presence of an expansile. There will be an expansile cough impulse. There will be presence of an expansile cough impulse. It's a reducible swelling. There is an expansile cough impulse is going to be present. Now, once the swelling comes, based upon where it has reached, you can differentiate into three different contexts, right? Now, every time you examine the hernia, you have to tell that whether it is a bubonocele, whether it is a funicular, is it a complete variety, right? Now, if the swelling is going to be only reaching the deep inguinal ring, right? So just for the sake of understanding, if I give you the context, if this is the deep inguinal ring, this happens to be the superficial inguinal ring, and let's say this is the scrotum, and this is the testes which is present here. Now, once the hernia sac starts to descend, if the hernial sac is going to descend and reach only to the deep inguinal ring, not beyond this, this is called as bubonocele. If it reaches all the way to the superficial inguinal ring, this is what we call it as the funicular variety. Now, if it reaches all the way, if it goes all the way and reaches onto the scrotum, this is called as a complete variety, right? So based upon whatever I've described it, if it is limited to deep inguinal ring, so if it is reaching to deep inguinal ring, this is what we call it as bubonocele. If it reaches to superficial inguinal ring, this is what we call as the funicular variety. And if it reaches all the way to the scrotum, if it reaches scrotum, it is called as a complete inguinal hernia. This is called as a complete inguinal hernia. Okay. So you have a reducible swelling. There is an expansile cough impulse is present. And when you try to palpate the superior extent of the swelling, you cannot, because it is inside the abdominal wall. So in inguinal hernias, you cannot get above swelling. You cannot get above swelling, right? Now, another thing, unlike like in hydrocele, there is transillumination present. Here, there will be absence of transillumination. There is absence of transillumination. There is absence of fluctuation sign. There is absence of fluctuation sign. There is absence of fluctuation sign, right? So it's a reducible swelling. There will be an expansile cough impulse. You cannot get above the swelling. There is absence of transillumination. There is absence of fluctuation sign, telling you that it is not a hydrocele. It is basically a hernia that you're looking at, right? So these are all the examination findings that you're going to be present. Now on examination, one of the most basic thing that you should evaluate is to see the differentiation. It is to see the differentiation between the direct and indirect inguinal hernia. So on examination, you have to do something called as ring occlusion test. So we'll talk about the ring occlusion test. Now this ring occlusion test is done to differentiate between direct and indirect inguinal hernia. This is done to differentiate. This is done to differentiate between direct inguinal hernia and indirect inguinal hernia. This is done to differentiate between the direct and the indirect inguinal hernia, right? Direct and indirect inguinal hernia. So how do you do a ring occlusion test, right? So the basic objective of doing a ring occlusion test, it's a stepwise approach. The step one, what is the first step? The first step, it is to reduce the hernia. It is to reduce the hernia. What is step 2? After you have reduced the hernia, you have to occlude the deep inguinal ring. Occlude the deep inguinal ring with your thumb, right? Now, after you have occluded deep inguinal ring with your thumb, step 3, ask the patient to stand. Ask the patient to stand. Now, once the patient stands, step 4. What is step 4? Ask the patient to cough. Ask the patient to cough. Now, when the patient is going to cough, I will have two representation. Either the swelling will reappear or it will not reappear, right? So, see, you need to understand that before doing this maneuver, no, the patient would actually present it with a swelling that is in the inguinal region. So, once you ask the patient to cough, I can have two results on cough. Either I can have a positive cough impulse or a negative cough impulse, right? Positive basically means that the swelling is able to appear even after occluding the deep inguinal ring. So that indicates that I am dealing with direct inguinal hernia. On the other hand, if the swelling does not appear, after occluding the deep inguinal ring, this indicates it is an indirect inguinal hernia. So all those intelligent people who are not able to understand why did this happen, so again the same analogy which is going to give you, let's say this in the context that we have already described it, no? So let's say this happens to be your external oblique aponeurosis, this is your superficial inguinal ring, this happens to fascia transversalis, is a deep inguinal ring which is going to be continuing across here, right? Now I am saying that all that you have to do is take your thumb, and after taking your thumb you have to occlude your deep inguinal ring. I have taken my thumb, and with the help of thumb I have now occluded the deep inguinal ring. Now once I occlude the deep inguinal ring, so I have reduced, see, first thing first, you have to reduce the hernia, right? So once I have reduced the hernia, now I have occluded the deep inguinal ring. Now once I have occluded deep inguinal ring, see, hernia has gone back, right? I have occluded deep inguinal ring. Now I am asking the patient to cough. If a patient had an indirect inguinal hernia, the hernia will try to enter from here, but your thumb says thank you, goodbye, tata, you are not allowed, right? Because the entry point is blocked, so it is going to be a negative cough impulse. A negative indicates indirect. On the other hand, if you are occluding a deep inguinal ring and the patient coughs and the swelling is going to appear from here, now that means what? If the patient had a direct inguinal hernia, this is an indirect one, this is a direct inguinal hernia. If a patient had a direct inguinal hernia, you are blocking the passage of indirect. Lekin direct ka to path khula tha, so obviously it is going to come across. So on occluding the deep inguinal ring, if the cough impulse is negative, that indicates it is indirect inguinal hernia. But if it is positive, it indicates direct inguinal hernia. And this is what we call it as ring occlusion test. This is what we call it as ring occlusion test. Okay? Now, once you have performed the ring occlusion test, now you know whether you're dealing with an indirect or a direct inguinal hernia, right? Now, we'd like to examine it, right? So, what are the investigations? What is the investigation with respect to inguinal hernia, right? Now, remember, hernia is a clinical diagnosis, and the only thing that I have to do in hernia is to differentiate between hydrocele and inguinal hernia, right? So, the first thing you have to write that the first investigation that you have done will be a clinical examination. And you have to write hernia is a clinical diagnosis. You will write hernia is a clinical diagnosis. The other things that you can go ahead and do it, it is going to be an ultrasound of the inguinoscrotal region. Now this is to confirm that whether it is a hernia or a hydrocele. Now whenever you have a complicated inguinal hernia, this has to be dealt with CECT abdomen. Get a CECT abdomen if it is a complicated inguinal hernia. Now what are the complications that you can talk about it, right? So what are the complications associated with inguinal hernia? Complications associated with inguinal hernia. Now the first complications are going to be less severe, and we'll keep on adding the more severe ones. The first one, it is going to be irreducibility. It is going to be irreducibility. Now this irreducibility is usually due to adhesions. So long-standing sac will have adhesions with the surrounding tissues, and that will not allow the hernia to reduce back. So irreducibility indicates some sort of a, either the ring is narrow, or the content is too much, or there is adhesion. So basically it is due to adhesions. Now along with irreducibility, it can have strangulation. It can also have obstruction. It can result in incarceration. And it can also have bowel perforation. Now, strangulation is basically what will happen when the pressure in that area of the bowel increases. Now, to give you all the explanations for this, now the easiest thing that I can do is, imagine that this is the sac that you have, right? And we talk about the content that is going to be present inside the sac. This is the content that we're talking about. Let's say this is the bowel that is entered here, right? We all know all bowel will have, let's say this is the mesenteric boundary of the bowel wall. This is the mesenteric part of the bowel wall. We all know the blood supply to the bowel actually comes from the mesenteric border. So if it is a blood supply, see the blood supply of the bowel comes from the mesenteric border. And as it comes from the mesenteric border, it is going to supply to every nook and corner of the bowel wall. So the blood supply comes from the mesenteric border. Now the concept is, you need to understand what is strangulation, what is obstruction, what is incarceration, what is the bowel perforation. Now in order to understand each an individual whatever we discussed, let's say, just for the sake of understanding, I'm just going to recreate this a bit. Now let's say this is the bowel that is present. This is the bowel wall, this is the proximal end, and this happens to be the distal end, right? This is the proximal end of the bowel, this is the distal end. Just to tell you, the content is going to move in this particular direction, right? Whatever content is there, it is going to move in this particular direction. Now what is an obstruction? Due to any reason, let's say the stools are getting blocked here. Now the stools are getting plugged. Because of this, the content which is supposed to flow in the forward direction is not able to flow. If a content is not able to flow in the forward direction because of some sort of an obstruction or some sort of an outlet passage difficulty, this is called as obstruction. So when there's an obstruction, any bowel obstruction will have same colicky pain, your nausea, vomiting, abdominal distension, abdominal pain, all that will be there. This is your obstruction. Now what is strangulation? Now once it starts getting obstructed, what will happen? There will be edema inside the bowel wall because it is getting compressed. Now when there is edema inside the bowel wall will now tend to swell up. Problem is, because it is in the sac, it does not have enough amount of space to swell up. So you will see as the bowel wall tends to swell up, it is now going to exert pressure on the inlet space. So the inlet is where the blood vessel is coming. If the blood vessel gets obstructed or gets compressed, the blood flow to the bowel wall decreases. So strangulation, the strangulation basically tells you that there is decreased vascularity. There is decreased vascularity of the bowel. Incarceration is called as impending gangrene. That means the ischemia has been for a prolonged period. It is going to result in the gangrene of the bowel wall. And obviously perforation is nothing but because of poor blood supply, it is your ischemia induced necrosis, right? So in bowel perforation, it is due to bowel ischemia induced necrosis, and that necrosis will result in perforation, right? So if you write this and you describe it, nobody is going to take any marks away from you. Irreducible, strangulation, obstruction, incarcerated, and the bowel perforations, right? So these are the complications associated with that of inguinal hernia. If you have any of these features, always get a CECT abdomen done so that you can rule out these particular contexts. Okay? Now, how do you manage it? Now, management of the inguinal hernia. Now this table that I'm going to draw, no, if you draw this table, again your examiner is going to be super impressed. So when talk about management of inguinal hernia, the first thing you will think like a surgeon and write your answer. Now management of the inguinal hernia, you have to see whether it is uncomplicated inguinal hernia or is it a complicated inguinal hernia. Whether it is an uncomplicated inguinal hernia, is it an uncomplicated inguinal hernia, or whether it is a complicated inguinal hernia. Whether it is a complicated or a uncomplicated inguinal hernia, right? Now, once you know, we have talked about all the complications. Now, if any of the complication is present, right? For example, if there is obstruction, if there is presence of obstruction, if there is incarceration, if there is perforation, any of this. Now what you have to do is, you have to take the patient for exploratory laparotomy. You have to take the patient for exploratory laparotomy. In an exploratory laparotomy, if bowel is fine. When you're in exploratory laparotomy, you have to see whether the bowel is injured or not, right? If the bowel is not injured, then you don't need to do anything. You can go with hernia repair. You'll see the status of bowel injury, whether there is any incarceration or any necrosis or any gangrene. If the bowel injury is present, then you have to go ahead with resection and anastomosis of the bowel. You'll go ahead with resection, anastomosis of the bowel, and hernia repair should be done later. Hernia repair is going to be later. In an infected state, you cannot put the mesh, right? That is not allowed. On the other hand, if there is no bowel injury, then you can go ahead with hernia repair. So the concept here is, whenever you have a patient who is going to have a complicated inguinal hernia, you have to see any of these obstructive features are present. If they are present, take the patient for exploratory laparotomy. On that, you see whether the patient has bowel injury or not. If there is no bowel injury, do a hernia repair. Otherwise, you have to go with resection and anastomosis, and the hernia repair should be different. If it is an uncomplicated inguinal hernia, then you have two options. Either you go ahead with open repair or open surgery, or you go ahead with laparoscopic hernia repair. You go ahead with laparoscopic hernia repair. Now, when you give an option of open surgery, in the open surgery, you have two methods. One, you can only opt for pure tissue repair. Another one is going to be mesh repair. So one, either we are going with tissue repair, or we are going ahead with mesh repair. Going ahead with mesh repair. So when we say tissue repair alone, so what are the examples? Just remember the name of the surgeries that are going to be with respect to tissue repair. So in the tissue repair, you have shoulders, you have bassinis, you have Desarda, you have Melanie, Dan, and all that. Remember, these three names are important. Shoulders, bassinis, and Desarda are pure tissue repair. So when I say a pure tissue repair, in a pure tissue repair, you are not using any mesh. There is no usage of mesh, right? On the other hand, if we are talking about the mesh repair, here I am going to use the Prolene mesh. So when you use a mesh repair, this is what we describe as Lichtenstein tension-free mesh repair. This is going to be Lichtenstein tension-free mesh repair, right? Now, the most common mesh use. So they will always expect you to tell the mesh material. When you are using a mesh, the material is important. The commonly used material, number one is going to be Prolene. Number two, it is polyester. And there is composite mesh. The most commonly used material, it is going to be Prolene. The most commonly used material, this is going to be a Prolene material. This is going to be Prolene material. Okay. Now, when it comes down to the laparoscopic hernia repair, so in laparoscopic hernia repair, you have to mention two techniques that are present. Two techniques in the laparoscopic hernia repair. It is going to be TEP and TAP. So we'll use two words. Number one is TEP, another one is TAPP. Now, what does TEP stands for? TEP stands for total extra peritoneal repair. That is total extra peritoneal repair. Then you have TAPP. TAPP stands for trans-abdominal. There's a trans-abdominal pre-peritoneal repair. It is a trans-abdominal pre-peritoneal repair, and this is what we call it as the TAP, right? So this is how you're going to talk about the various hernia repairs, right? Now, just to add the last thing on the icing on the cake, you have to describe three terms that they expect you to tell. What is herniotomy? What is herniorrhaphy? And what is hernioplasty? So three terms that is expected for us to describe. So when we say herniotomy, in an herniotomy, it is opening of sac in indirect inguinal hernia and reducing content. And reducing the content. When I say reducing the content, it is basically to push the content back into the abdomen. That is called as the herniotomy. You will not do herniotomy in a direct inguinal hernia, because in the direct inguinal hernia, we all know sac is formed of fascia transversalis, and fascia transversalis is actually a component of abdominal wall. So if you incise an abdominal wall layer, you are only going to cause weakness. What is herniorrhaphy? It is going to be only tissue repair. So in a tissue repair, so in herniorrhaphy, what do? You do herniotomy. If it is an indirect hernia, you'll do a herniotomy, and after that, we are going to strengthen the posterior wall. We are going to strengthen the posterior wall. Hernioplasty is usage of mesh, so it is going to be a mesh repair. So I'm going to do the same thing. You'll do a herniotomy, you will do a posterior wall strengthening, and then you will put a mesh on top so that it fixes across it. This is what we call it as hernioplasty. This is what we call it as hernioplasty. Now, never end your answer without writing the complication of the surgery that you have done. The last point is going to be post-operative complications. So what are the post-operative complications of inguinal hernia repair? Of the inguinal hernia surgery. So when you talk about the post-operative complications, number one, it will result in acute retention of urine. Acute retention of urine, hemorrhage, injury to vas deferens, nerve injuries are common. Now when you talk about the nerve injury, couple of important things. Most common nerve injury, the most common nerve injury in open hernia repair, open inguinal hernia repair. On an open inguinal hernia repair, it is going to be ileoinguinal nerve. It is going to be the ileoinguinal nerve, right? Most common nerve trapped in mesh. Most common nerve trapped in mesh. So when you put a mesh, sometimes it can encase a nerve, and that is going to be the iliohypogastric nerve. It is the iliohypogastric nerve. The most common nerve injured in laparoscopic hernia repair. The most common the most common nerve injured in laparoscopic inguinal hernia repair. Laparoscopic inguinal hernia repair, right? And that is going to be your lateral cutaneous nerve of thigh. It is going to be the lateral cutaneous nerve of thigh. This is going to be the lateral cutaneous nerve of thigh. Okay. So this is how you write your answer. So we started our answer of the inguinal hernia by definition. Then we spoke about the inguinal canal anatomy. Then we spoke about the difference between direct and indirect inguinal hernia. Then we spoke about the clinical presentation, investigation, surgical management, approach, post-operative complications, right? So this is how you're going to write your answers for inguinal hernia, right? So did we cover all the points that we have intended to? Did we cover inguinal hernia? We did. Complications in hernia and management did. A difference between indirect and direct inguinal hernia, we did so, right? So this is what you should know in the context of inguinal hernia, right? So far, any doubts, any questions, quick feedback? Okay. Aishwarya, if you are asking, sir, SRB or Manipal? Okay. If you have to pick one, I shouldn't be endorsing any of them. But then when we were in our post-graduation also, SRB is considered to be slightly more better because it is giving more, I will say, point-wise this thing. So if you want to prefer out of Manipal and SRB, go with SRB, right? If you want even better source, if you want to learn even better, then the answer is going to be Bailey and Love, right? There is no replacement for Love and Bailey. Every single student who is in the final year should read Bailey and Love, right? So there is no if and but. Just before the exam, yes, to brush it, revise it, you can switch to other books, but I strongly recommend to read Love and Bailey, at least the volume 2. ठीक है, वॉल्यूम 1 में चलो थोड़ा दिक्कत हो गया, वॉल्यूम 1 वी कैन यूज इट समवेयर एल्स, बट वॉल्यूम 2 हर किसी को पढ़ना है, दैट इज द ट्रू आर्ट ऑफ जनरल सर्जरी दैट, ठीक है, तो उसको नहीं छोड़ना है. क्लियर? ठीक है, कैन वी मूव ऑन? So the next topic that we're going to talk about is going to be pancreas. Pancreas में एक सवाल आया था, that is going to be acute pancreatitis. So we'll talk about acute pancreatitis. चलें? ठीक है. So one question that was asked in our exams, repeatedly asked from the pancreas, the question was on acute pancreatitis. So there were subparts to this question. They've asked you the causes of acute pancreatitis. They've asked you the clinical features and management. There is clinical features and management. There is complications associated with acute pancreatitis. Complications associated with acute pancreatitis. ठीक है? So our job is to address all of them. Again, in a single framework, we'll try to summarize all the answers. Again, as we've been doing this. Again, if you talk about the marks distribution, the causes, the entire list was for 3 marks. The features and the management was 5 marks. Complication was 5 marks. There's a question which had a combination of both, which is going to be for 10 marks. Okay? So pancreatitis per se is important, especially when you talk about the acute pancreatitis, right? So when you talk about acute pancreatitis, let's talk about how to write the answer for this. So we'll talk about the answers for acute pancreatitis. Now, when I say acute pancreatitis, it is defined as acute inflammation of the pancreas. It's simple, nothing more than that. So, an acute inflammation of the pancreas. Now, we need to know what leads or what causes this acute inflammation of the pancreas that usually occurs, right? So, in an acute pancreatitis, let's look at the causes. What are the causes for acute pancreatitis? Now in the cause, the most important is going to be gallstones. In fact, gallstones happens to be the overall most common cause for acute pancreatitis. They are the overall most common cause for acute pancreatitis. The gallstone from the gallbladder falls into the common bile duct. From there it goes into the ampulla and blocks the ampulla, not allowing the pancreatic enzymes to excrete out, resulting in acute increase in pressure, inflammatory response, resulting in acute pancreatitis. So gallstone is overall the most common cause for acute pancreatitis. Apart from gallstone, the second one is going to be alcohol. Alcohol is the second most common cause. Alcohol generates free radical oxygen. Those free radical oxygen goes and damage the pancreatic SNR cells, and then that disruption of cells will result in development of acute pancreatitis. Now other causes that are important is going to be post-procedure like ERCP. ERCP stands for endoscopic retrograde. Endoscopic retrograde cholangiopancreatography. The endoscopic retrograde cholangiopancreatography, that is your ERCP. Metabolic disorders, example like hyperparathyroidism, hyperlipidemia. Hyperparathyroidism as well as hyperlipidemia. Now it is also secondary to the blunt trauma abdomen. So in the blunt trauma where there is pancreatic injury, and that pancreatic injury is going to result in the same, right? So there is gallstones, alcohol induced, ERCP, hyperparathyroidism, hyperlipidemia, blunt trauma to abdomen. There are infections which are important, certain viruses, Coxsackie virus. There is Coxsackie virus. Then there is mumps virus, and there is echovirus. All these viruses are also known to cause acute pancreatitis, right? Now your examiner will be more interested in knowing whether you know the drugs that induce acute pancreatitis. Now the list of drugs are important. Drugs that result in acute pancreatitis: number 1, cytarabine. Antibiotics like aminoglycosides. Antiepileptic like valproate. Diuretics like thiazide. So cytarabine, aminoglycosides, valproate, thiazide, tetracycline, estrogen supplementation, pentamidine, trimethoprim, mercaptopurin, and the last one is aminosalicylic acid. Right? So these are the drugs which are known to cause acute pancreatitis. So the list is important. At least 5 you remember. If you can't remember all 10 drugs, at least remember 5 drugs that result in acute pancreatitis. Right? Now, in order to understand the pathophysiology of acute pancreatitis, it is going to be a huge disruption in the pancreas, which are going to present to you as symptoms. Right? Now, how does the patient present to you? We'll talk about the clinical features of acute pancreatitis. Clinical feature of acute pancreatitis. So we'll talk about what are the clinical features of acute pancreatitis. Number 1, see, it's an inflammatory disorder. An inflammation anywhere in the body will have rubor, calor, dolor, tumor, right? So I cannot see redness, I cannot see the swelling of the pancreas. I can see that on an imaging, that is CT, but otherwise I will not be able to see. But the other two I can quite well appreciate, right? So when you talk about the clinical features of acute pancreatitis, if you have worked in casualty, it's like a small story that you have to remember. any patient of acute pancreatitis will present to you. He'll present to you with sudden severe onset of epigastric pain. There is a sudden severe onset of epigastric pain, but it is not just an epigastric pain. If you talk to this patient, you will say that this is a radiating pain. The patient will tell you that this is a radiating pain. So where does it radiate to? Remember, it is going to radiate to the left side of the back. So from the epigastrium, it is like a band radiating to the left side of the back. Second thing, you will say, is there any precipitating or relieving factors? The patient will say that the component of pain reduces on bending forward. Component of pain reduces on bending forward. On the other hand, the component of pain increases on lying down supine. I hope you know the concept behind it. Just in case if you don't, I'll give you a quick component of why the pain is going to be variable in these patients. Now what happens is, if you have seen a patient, let's say this is the patient who is going to come. Okay? Now if you take this is a representation of the patient, and let's say this is the abdomen that is present. Okay? Now this is going to be a peritoneal surface which is present here. Pancreas, we all know it is retroperitoneal in origin. So it is retroperitoneal. Now right in the intra-abdomen you have the bowel that is present across here. Okay? Now what is going to happen is you will notice that this patient, whenever he comes in, he will not like to lie down supine. In fact, he will go find a nice wall, or initially he'll try to find a small stool, chair or table where he is likely to sit in this position where the patient would lean forward. This is the abdomen, and you would see the hands are tucked into the tummy, right? He is bending forward or leaning forward. On the other hand, if you say this is your chair and you don't want him to sit and you push him away, so he's, poor fellow, he does not have anywhere to go. So now he finds a wall. Now in the wall, he's going to stick his head like this, and then he is going to stand like this. He is standing in this particular position with the same reason. So why is he trying to bend forward or lean forward? The object is quite simple. As I told you, the pancreas are going to be retroperitoneal. When the patient bends forward or leans forward, the bowel is going to fall over the abdominal wall. Now, as you can see, the bowel is falling on the abdominal wall. The pressure on the pancreas is relieved. But when he lies down supine, the entire bowel is going to fall and sit onto the pancreas, which is going to exert more pressure. On inflamed gland, if you exert more pressure, the component of pain increases. So patient says, sir, I am fine bending or leaning forward. I would not like to lie down supine. So that's the first thing that you will notice in these patients, that is going to be with respect to pain. Now these patients will also be associated with nausea and vomiting. Now why there is a nausea and vomiting? We all know pancreas sits on the posterior surface of the stomach, and there's a nerve that runs through that. That is nothing but your vagus nerve. The vagal irritation due to pancreatitis will result in nausea, vomiting. So nausea, vomiting in acute pancreatitis is because of vagal irritation. It is because of vagal irritation. They will also be associated with non-passage. There will be non-passage of stools and flatus. Remember, every single intra-abdominal inflammation will result in a condition called as paralytic ileus. In paralytic ileus, basically the peristalsis sees this stop, and the paralytic ileus is seen in every other condition where you have intra-abdominal inflammation. It could be colitis, it could be intra-abdominal abscess, it could be pancreatitis, anything. Any intra-abdominal inflammation will result in paralytic ileus, right? So there is severe pain, there is nausea, vomiting, there is non-passage of stools and flatus is the initial presentation of acute pancreatitis. Now obviously I would like to examine, so I would tend to examine. So on examination, what are the findings that you are expecting on examination? First of all, he won't let you touch, but somehow you are able to touch. What are the findings that you'll see? The first finding, there will be severe tenderness. There will be severe abdominal tenderness. There will be presence of severe abdominal tenderness. Patient is going to have guarding. Guarding is not letting you touch. There's no rigidity. Rigidity is seen in peritonitis. Guarding is seen in severe abdominal pain or intra-abdominal inflammations, right? So there is severe abdominal tenderness is present. The guarding is present. Patient is not allowing you to touch. You auscultate with this TED. There will be absence of bowel sounds. Now the bowel sounds are absent because of paralytic ileus. They're absent because of paralytic ileus. Now, because it's an inflammation tends to have friable tissues. They can bleed. When they bleed, they can present to you as retroperitoneal hemorrhage. They can present to you as retroperitoneal hemorrhage, and this is what we call it as the hemorrhagic pancreatitis. So in a retroperitoneal hemorrhage, there are two signs that you should know. One, there will be discoloration of the flank, and there is discoloration of the periumbilical region. So if there is discoloration, that is ecchymosis, or discoloration of flank region is noticed, and there is discoloration of periumbilical region, Flank, if it is discolored, this is what we call it as the Great Turner sign. Discoloration of umbilicus is what we call it as the Cullen sign. So ecchymosis of the flank is what we call it as a Great Turner sign. Discoloration of the periumbilical region is what we call it as Cullen sign. Okay? So on examination, these are the findings that you're going to present. Apart from that, because there is severe volume loss, these patients can also be in shock. So they can have tachycardia, they can have hypotension, and they'll also have tachypnea. So tachycardia, hypotension and tachypnea indicates there is excessive volume loss, so patient may be in shock. So these are the examination findings, right? Now when a patient comes to you with acute pancreatitis, right, what are the investigations that you are going to run by the patient? Now here is the rule that I would like to tell you for any intra-abdominal pain. Okay. Any patient who comes with intra-abdominal pain, always start with the ultrasound of the abdomen. So the first investigation that I would do is going to be an ultrasound of the abdomen. See, USG abdomen is not a great tool because there's a lot of bowel chatter. There's paralytic ileus, the content is there only, the bowel is distended. So because there is distension, there is air, and because there is air, and you put an ultrasound probe, and whenever you send a sound waves in an empty space, it is going to resonate. And because of that resonation, what is going to happen? There will be a lot of disturbance that is going to be developed, or there will be a lot of echoes that are developed. So under that, there is pancreas will not be able to see properly. But again, USG abdomen can tell you whether the pancreas have become bigger or not. Bulky means edematous pancreas or not. Now, once you're done with the USG, you can also get an erect X-ray abdomen. Now, this erect X-ray abdomen, basically, see, when you look at the features now, they also look like intestinal obstruction. So what are the X-ray findings that you will see? On an X-ray finding, you can see presence of sentinel loop sign. There will be presence of sentinel loop sign. There will be presence of colon cutoff sign. There is a sentinel loop sign. There is colon cutoff sign. There will be renal halo sign. There will be this renal halo sign, and there is ground glass appearance. The sentinel loop sign, colon cutoff sign, renal halo sign, and the ground glass appearance. All these are present on an X-ray, right? But if I say, how do you confirm? Remember, the best way to confirm, it is going to be the clinical examination with lab investigations. Now in the lab investigation, two most reliable one, that is going to be serum amylase. You see there is serum amylase as well as serum lipase. See, both of them will be elevated in acute pancreatitis. See, amylase is also produced in the salivary gland, so which is specific for pancreatitis. It is the elevated serum amylase which is going to be specific for pancreatitis, You can also get the CECT abdomen. Now CCT abdomen is done to rule out hemorrhagic pancreatitis. As well as pancreatic necrosis. So whenever there is acute inflammation, it can also result in pancreatic necrosis. To rule out the pancreatic necrosis, you can get a CCT abdomen. So that is why we don't get the CT immediately. We'll wait for initial 4 or 5 days, give the treatment if it is not resolving, and that is when the best time to get the CT done actually, right? So these are with respect to the investigations associated with your acute pancreatitis. Now you have a working diagnosis of acute pancreatitis. Now, once you have a working diagnosis of acute pancreatitis, how would you like to manage? So talk about the management of acute pancreatitis. So we'll start with the management. Management of acute pancreatitis. Now I talk about the management of the acute pancreatitis. But BLS में pancreas will take time now. Abhi, I think from this Monday onwards, that is from day after tomorrow, BLS we are starting hernia. ठीक है, hernia के बाद we'll go into GIT, और GIT में we'll start with the esophagus, and then we'll go into hepatobiliary pancreas is going to be in a later session only. I think June July तक हो जाएगा pancreas. चलो, now in acute pancreatitis is excessive volume loss. So the stepwise management, the first one, I'm going to secure 2 large IV cannula. Start the patient on IV fluids, preferably ringer lactate. Start the patient on adequate analgesia. Right? So secure 2 large IV cannulas, ringer lactate, adequate analgesia. This is the prime finding that you'll do. Now most of them is going to have paralytic ileus, so keep the patient NPO, that is nil per oral. That means don't give any oral feeds if there are presence of paralytic ileus. Do not feed the patient, and in fact you have to do pancreatic rest. So ideally you keep the patient nil per oral. Okay? So you have to keep the patient nil per oral, start the patient on IV fluids, give adequate analgesia. Now once you have given this, I am going to wait for 24 to 48 hours. After 24 to 48 hours, I am going to repeat the complete blood count, and in the CBC, if the WBC counts are elevated. If WBC is elevated, then I will start the patient on antibiotics. Otherwise, there is no role of antibiotics to be given in acute pancreatitis. Majority of the patients respond to the conservative line of management, so you don't need to really worry about it. Okay? So this is how you're going to manage your acute pancreatitis in a conservative line of component. Okay? Now, what are the for the assessment of the severity? For severity assessment of acute pancreatitis, you don't need to write the entire protocol for severity assessment. Just remember the severity assessment tools that we are going to use, right? For severity assessment, number 1, we'll be using Ranson score. Number 2, I'll be using Glasgow score. Or you can say modified Glasgow. We'll be using Atlanta classification. Then you have the Apake score. that is acute physiological and chronic health education score. Acute physiological and chronic health education, and obviously CRP, that is a C-reactive protein, are the ones which are going to look for severity assessment, right? You don't need to go and remember the entire Ryanson's criteria, which is not important, but this is what you should look across. That is severity assessment. Now, what are the complications associated with acute pancreatitis? This will be a last point to summarize. Complications associated with acute pancreatitis. Complications associated with acute pancreatitis, right? So when we talk about the complication list, we'll be dividing the list of the complications into two. One, we'll talk about the local complications. Another one is going to be systemic complications. So we have local complication, and systemic complication. We have the local complication and the systemic complication. The local complication and the systemic complication. Now, what are the list of the local complication that you have? In the list of local complication, number one, acute fluid collection, acute peripancreatic fluid collection, acute peripancreatic fluid collection, acute necrotic collection, acute necrotic collection, pseudocyst of the pancreas, Another complication is called as WON, which is called as ward of necrosis. It's called as the ward of necrosis because the tail of the pancreas sits into the splenic hilum. It can result two complications in spleen. Number one is splenic vein thrombosis. And number two, it is your splenic artery pseudoaneurysm. Right? So the peripancreatic fluid collection, acute necrotic collection, pseudocyst of the pancreas, ward of necrosis, splenic vein thrombosis, splenic artery pseudoaneurysm. It can also result in a fistulous communication between the left side of the thorax, right? So pancreatopleural fistula, and that is usually on the left side. So it will result in less left pleural effusion. This will result in left pleural effusion, right? These are the complications with acute pancreatitis. Now, when you talk about the systemic complications, in the systemic complications, it is associated with SIRS, that is your systemic inflammatory response syndrome. Systemic inflammatory response syndrome. Resulting in sepsis, then going into septic shock. From septic shock, it can result in acute respiratory distress syndrome, that is ARDS, and eventually resulting in MODS and death. ARDS is acute respiratory distress syndrome. So systemic inflammatory response syndrome, sepsis, septic shock, ARDS, and MODS, right? So these are the complications, the systemic complications associated with acute pancreatitis. Let's start with the first topic. That is going to be carcinoma stomach. So they've asked you every single possibility in the carcinoma stomach. They've asked you to write down the classification. They've asked you to the management of CA stomach. They asked you what are the risk factors for CA stomach. So we'll start with the entire components the same. So we'll be talking about the carcinoma stomach. So when we talk about the carcinoma stomach, first of all, we'll talk about the risk factors, right? So what are the risk factors that can result in, what are the risk factors? What are the risk factors that can result in carcinoma stomach? So I can divide the risk factors into 4 categories. One is your nutritional risk factor. Another one is the environmental risk factor. You have the nutritional risk factor, the environmental risk factor, you have medical risk factors, and then you have miscellaneous or simply categorized as others, right? So when it comes down to the nutritional risk factors, any patient who has a low fat intake or low protein intake. Low fat or low protein intake can induce, or I can say increase the risk for CA stomach. Then if there is a patient consuming salted meat. Now this salted meat can be a salted fish also, which is dried, again increase the risk for CA stomach. Food which is rich in nitrate, so high nitrate rich food or the high nitrate consumption. Increase nitrate consumption. Increased nitrate consumption, obesity, and consumption of complex carbohydrates. Patient consuming complex carbohydrate. So these are the nutritional risk factors that can increase the risk for CA stomach. Now what are the environmental risk factors? When you look at environmental risk factor, any factor or any risk factor that can increase the risk of H. pylori's infestation. For example, when you talk about it, poor food preparation. There is poor food preparation, lack of refrigerator, and poor drinking water. Poor drinking water. So poor food preparation, lack of fridge, and poor drinking water. All these conclude as the environmental risk factors. Now I talk about the medical risk factors. In the medical risk factors, you have prior gastric surgery. Prior gastric surgery. H. pylori induced infections that can result in atrophic gastritis or else peptic ulcer disease. Any radiation exposure. Previous radiation exposure associated with atrophic gastritis. And presence of adenomatous polyps. Now in the miscellaneous risk factor or the other risk factors, being a male is a risk factor, and especially if you are poor, it is a bigger risk factor. So low socioeconomic status. It is the low socioeconomic status, right? So these are the risk factors that are going to result in carcinoma stomach, right? Now, when you talk about the carcinoma stomach, well, let's talk about the clinical features. In terms of clinical features, I'm going to tell you about based upon the site. So you can draw the site of the stomach. Let's say this is the esophagus, this is the gastroesophageal junction. Now, to be very honest, I don't want you to confuse more, but according to the Sievert classification, the CA stomach will start 2 centimeters below the gastroesophageal junction, right? So 1 centimeter above and 2 centimeter below the gastroesophageal junction is still considered to be as esophageal carcinoma. It is still considered to be as esophageal carcinoma, but to avoid any confusion, I will divide the stomach into 3 parts. That is the proximal part of the stomach, the mid body, and the distal part of the stomach, right? So clinical features will be of typical. We've got typical features. Typical features. If it is present in the proximal third of the stomach, if it is in the proximal 1/3 of the stomach. Now, if it is the proximal 1/3 of the stomach, it's a very logical thing. No? Imagine there's a tumor that is growing across here. Now, if the tumor is growing here, obviously it is obstructing the lumen. Now, if it is obstructing the lumen, the food cannot go inside. Now, if obviously initial presentation of these patients would be of dysphagia. It will be of dysphagia. It will be associated with dyspepsia as well. It will be dysphagia, dyspepsia, and remember all tumors will have neovascularization, so it will be highly vascular. So whenever the food brushes, whenever the food passes, it will brush with the tumor. Now as it brushes with the tumor, it is going to bleed, and that bleed will present to you as upper GI bleed. Now I hope everybody knows the features of an upper GI bleed. Whenever I say upper GI bleed, I associate 3 conditions. Number 1, there is presence of hematemesis, that is blood vomiting. Along with that, it will be associated with, whichever blood goes up will go down also, it will be associated with melena, and obviously blood loss will result in anemia. So it is hematemesis, melena, and anemia is what we call it as the features of upper GI bleed. It will be associated upper GI bleed. When it comes to dysphagia, it is usually for solids when compared to liquids. So dysphagia will be more for solids when compared to liquids in any form of malignancies associated with the stomach or with the esophagus, right? So the proximal 1/3, this is going to be the presentation that you will see. Now, mid body are usually delayed presentation. So if you say mid body, they have delayed presentation. They are usually associated delayed presentation, or they can present to you as upper GI bleed. They present as upper GI bleed. Then it is the distal 1/3 of the stomach. There is a distal 1/3 of the stomach. Now I say distal 1/3 of the stomach. Imagine if a tumor is developing at the distal 1/3. What it will cause, it will not allow the content to move out. So it is occupying that lumen. No. Now as it is not allowing the content to move out, there will be gastric outlet obstruction. So here the features would be of gastric outlet obstruction. There will be gastric outlet obstruction. So in this gastric outlet obstruction, what are the features that you will see? The patient will have recurrent episodes. There will be recurrent episodes of non-bilious vomiting. Now, why non-bilious? I hope everybody knows it, that the bile duct is going to open onto the terminal part of the second part of the duodenum, and the obstruction is above the level of duodenum. So there's a repeated episodes of non-bilious vomiting. So there is recurrent vomiting is there. It will be associated with abdominal pain. This will be associated with abdominal pain. This will be colicky in nature. There will be colicky in nature. It will also have visible peristalsis. Now, if you want to impress your examiner, you can say the visible peristalsis here is going to be from left to right. So the wave of peristalsis that you see here is going to be left to right because the orientation of stomach is left to right. Colonic peristalsis are going to be right to left. Gastric peristalsis are left to right. So this is how you know you're looking at a visible, you're looking at a gastric or a colonic I would say peristalsis. Okay? So this is on the basis of proximal 1/3, mid body, or the distal 1/3 of the stomach. These are the typical features that you're going to see. Now along with that, the common features which will present in all. The common clinical features. The common clinical features that you will see in all the presentation of CA stomach. There will be presence of abdominal pain. There will be presence of abdominal pain. It will be associated with 3 A's, that is anemia, anorexia, as well as asthenia, that is tiredness, right? Then you have significant weight loss. it is associated with significant weight loss. So abdominal pain, anemia, anorexia, asthenia, which is called as the triple A of any malignancy. And then you have significant weight loss. Then you have the significant, I hope everybody knows, no, significant weight loss. How much is a significant weight loss? When more than or equal to 10% of the body weight, there is decrease. There is more than or equal to 10% of body weight reduced in more than or equal to 180 days, that is 6 months, which is an unintended weight loss. This is an unintended weight loss. This will be called a significant weight loss. So all these which I've learned are the typical features of the carcinoma stomach. Then there's something called as the atypical features. So we'll talk about the atypical features of CA stomach. We'll talk about the atypical features of carcinoma stomach. So what are the atypical features of the CA stomach that we have? Number one, you have enlarged lymph nodes. Where else do you see? See, the enlarged lymph nodes will come from top to bottom. So it will be enlarged. There is this enlarged left supraclavicular. There's an enlarged left supraclavicular lymph node. Now this enlarged lymph node name is what we call it as the Virchow lymph node. And this sign is what we call it as the Trozier sign. That is, enlarged left supraclavicular group of lymph node is what we call it as the Trozier sign, right? Now, apart from that, you have enlarged left supraclavicular, right? You have the enlarged left supraclavicular, and then you have enlarged axillary, right? So you have the enlarged left axillary group of lymph nodes. Now, this enlarged left axillary group of lymph nodes is what we call it as the Irish group of lymph nodes. Then you have enlarged periumbilical group of lymph nodes. This is your enlarged periumbilical. This is an enlarged periumbilical group of lymph node. And this enlarged periumbilical group of lymph node is what we call it as the Sister Mary Joseph. This is Sister Mary Joseph group of lymph node. This is your Sister Mary Joseph group of lymph nodes, right? So you have the Trozier sign, you have the Irish group of lymph nodes, and the enlarged periumbilical group of lymph nodes are called as Sister Mary Joseph group of lymph nodes. Now, apart from that, it can also be associated with migratory superficial thrombophlebitis. And this is what we call it as the Trosseux syndrome. See, enlarged lymph node is what we call it as the Trozier sign, and migratory superficial thrombophlebitis is what you call as the Trosseux syndrome, right? This is what we call as the Trosseux syndrome. Now, apart from that, it can also have the what happens when the tumor, CA stomach, no, tumor which is arising from the mucosa, it pierces the entire wall, goes to the serosa, and then it will start falling into the peritoneal cavity. In females specifically, that drop metastasis can go into the liver, into your ovaries and regerminate, and that is what we call it as the Krukenberg's tumor. It's what we call it as the ovarian metastasis. What is the ovarian secondaries? Then the same drop metastasis can go into your rectovesical pouch, and that is resulting in, all that collection will result in rectal indentation, and that is what we call as Blummer shelf. It's called Blummer shelf, and this is what we call it as rectovesical. We call it as, or they can say pelvic metastasis. These are pelvic secondaries. Skin lesions that you can see, number one is going to be the lesser Trillat sign. Lesser Trillat sign. And another one that you get is going to be tripe palm sign. You have the lesser Trillat sign and the tripe palm sign. Now, what is your lesser Trillat sign? Your lesser Trillat sign is nothing but multiple seborrheic keratosis. There's a multiple seborrheic keratosis. And your tripalm sign is nothing but hyperkeratotic palm. And a hyperkeratotic palm. Now remember, in lesser triad sign, this multiple seborrheic keratosis. Now you will have patches, the skin patches. In tripalm sign, you will have scaly palms. You will have scaly palms. So these are the atypical features of the carcinoma stomach, right? Now, whenever you have a patient who has presented with the CA stomach, I would like to evaluate. Obviously, when you have features of upper GI bleed, any patient with upper GI bleed, you have to evaluate it. So in terms of investigation, what are the investigations that we can do? So looking at the investigations. So the investigations that we can perform here, the first investigation would be your upper GI endoscopy. So in an upper GI endoscopy, there will be presence of growth. Now in this presence of growth, you have to take a biopsy. So we will take a biopsy from the upper GI endoscopy. Now based upon this biopsy, we have a classification, or I can say based upon the HP, we have a classification which is called as the Lauren classification. So what is this Lauren classification? In the Lauren classification, you can have two types of the CA stomach. Number one is the intestinal type of CA stomach. And number two, there could be a diffuse variety or the diffuse type of CA stomach. Now, the criteria in which you will be looking at is the sex, which is usually going to get involved, the usual age of presentation, the genes which are associated with this, is there any specific risk factors. Then you talk about the mode of spread, for these malignancies. Then you have what is the HP findings that you can have and what is the prognosis. So this is the line on which we are going to ask the questions. Now talk about the intestinal variety. The intestinal variety, it is more common in males when compared to females. Diffuse variety is more common in females when compared to males. The usual age of presentation for intestinal variety is age above 50 years. It is relatively seen in younger age group, that is 30 to 40 years. The genes which are associated here is going to be your APC gene, P53 gene, and P16. Here it is associated with E-cadherin gene mutation. Along with that, along with E-cadherin, there is P53 and there is P16 mutation. Is there a specific risk factor? Here it is associated with intestinal metaplasia. It is intestinal metaplasia, and the diffuse variety is associated with blood group A. It is associated with blood group A. The mode of spread is going to be hematogenous, that is blood, whereas here it is usually associated with direct or lymphatic spread. Direct or the lymphatic spread. HP is usually a gland forming variety. Usually you see a gland forming variety. Here you will see presence of signet ring variety. Here it is relatively a good prognosis, and here it is going to be relatively a poor prognosis. Now this is something that you have to remember from our exam perspective, that is a Lawrence classification. If you do, when you talk about CA stomach and you mention Lawrence classification, then your examiner is bound to get impressed. There is no if and but in that. That means you understand the oncology principles and its management, and that is what your Lawrence classification is trying to tell you. Okay? So this is the difference between the intestinal and the diffuse variety that you will see in CA stomach. What are the other investigations that you can do? Now once you have confirmed it, remember I can also do an endo ultrasound to know the T staging. I can do a PET CT as well. Now PET CT is basically to look for staging. The PET CT is done for staging. Okay. Now, based upon the same upper GI endoscopy, the image classification that you have. So based upon the upper GI morphology, when you do an upper GI endoscopy, and based upon the morphology that you see on the endoscopy, we have two variants of gastric carcinomas that you have, which can be classified. Number one is going to be your Japanese classification. Another one is going to be your Borman's classification. Your Japanese classification and the Borman's classification. Now, it is both on the basis of your upper GI endoscopy, right? Now, Japanese is classified for early GI malignancies. And Borman's is for advanced GI malignancies. Borman is going to be of advanced GI malignancy. Hi guys, good evening. Okay. So in the Japanese, how does it look like? I'll just quickly run through the basic objective. So imagine if this is the tissue block that we have, right? So I have different varieties. We're just going to name them. I need a couple of them, so I'll just quickly add them here, add them further here. I need 5 of them. So 4, then 5. What I'll do is I'll take this entire thing, copy it, and put it here. Smart, right? So you have the early for your Japanese and the Borman. So let's look at the growth presentation, right? Now, when you look at the early gastric cancers, the type 1 variety will have a protrusive growth like this. This is the growth which is going to be present here. In type 2 variety, it will be a flattened growth. It is going to be like this. Type 3, it is going to be in the same level. It is going to be in the same level of the tissue. In type 4 variety, you see there is an ulcer being formed, but this is only just depressed. So the small ulcerated form which is here. And the next variety is going to be completely digging in, which is called as an excavated variety. So see, it is going to be like this. This is excavated. So if I put these into perspective, this is what we call as type 1 variety. This is your type 2A variety. This is your type 2B variety. This is your type 2C variety. And this is your type 3 variety. Now type 1 variety is what we call it as the protruded variety. This is your protruded variety. This is flat and elevated. This is 2B is only flat. 2C is only depressed. And type 3 is going to be, it is going to infiltrate into the surrounding wall. So it is called as excavated. So we have the protruded variety, flat and elevated, flat, depressed, and the excavated. This is your early GI malignancy. Let's say if this is an advanced GI malignancy. So in an advanced GI malignancy, number 1, you will see presence of a polyploidal growth. Number 2, you see there is an ulcerated lesion, but this ulcerated lesion is going to have an elevated margin like this. The third variety is going to be only an ulcerated lesion. There is an ulcerated lesion. 4, it is going to involve a transmural thickening, which is like this. And this is going to be non-classifiable, something like this, right? So this is your type 1 variety, this is your type 2 variety, this is your type 3 variety, this is your type 4 variety, this is your type 5 variety. Type 1 is what we call it as the polyploidal type. It's the polyploidal type. Type 2 is ulcerated lesion. It's an ulcerated lesion with elevated margin. With elevated margin. This is only an ulcerated lesion. Type 4 variety is going to be, it is going to infiltrate the entire wall, and one of the histopathological name that you have is the Linitis plastica. This is the Linitis plastica, and type 5 is non-classifiable. Type 5 variety is your non-classifiable. Type 5 variety is a non-classifiable. So this is about the Japanese variety, and this is about the Borman's classification. For the Borman's classification. Then comes the TNM classification for CA stomach. In the TNM, T is the size of tumor, N is the lymph node, M stands for metastasis. You have T1A, which is only involving the lamina propria. If the tumor involves only the lamina propria, it is T1A. Then it is T1B, which is only going to be involving the submucosa. Then you have the T2 variety, where it is only involving the muscularis. It is only involving the muscularis propria. Then you have T3 variety, where it is going to involve the subserosal space. Then you have the T4A variety, which is tumor perforate serosa. Tumor perforates serosa. Then you have T4B, where tumor involving adjacent organ. Tumor involving adjacent organ, right? So this is going to be lamina propria. So T1A is involvement of lamina propria, then you have the submucosa, then you have the muscularis propria, then you have the serosa, then it's beyond serosa, and ultimately it is going to go and invade to the surrounding organs. Okay, that is your T status. When it comes down to lymph nodes, the lymph nodes N0, there is no evidence of any lymph nodes. No evidence of enlarged lymph node. Then you have N1, where you have 1 to 2 regional lymph nodes are positive. N2 variety, where you have 3 to 6 regional lymph nodes are found to be positive. N3A, you have 7 to 15 regional lymph nodes are positive. And N3B is lymph nodes more than or equal to 16 are positive. Right. So this is, I recently had a laparoscopic cholecystectomy and ERCP. Okay, Manas. Fine. So these are the N staging. M stands for M0. There is no evidence of metastasis. There is no evidence of metastasis. M1, there is evidence of distant metastasis. There is an evidence of distant metastasis. Clear? Sure. So, once you have the staging, let's talk about the management. We have the management. Management of carcinoma stomach. So in the carcinoma stomach, we'll see whether it is operable or whether it is inoperable. Whether it is an operable or whether it is an inoperable malignancy. Inoperable is like, distant metastasis and everything is present. There's no point operating. In this patient, I would basically allow the patient to feed. So the whole problem is about feeding. So here in an inoperable condition, if it is associated with obstruction, that is gastric aortic obstruction, you can do a feeding jejunostomy, or you can also try something called as SEMS. SEMS is your self-expanding. It is the self-expanding metallic stent. Right? Inoperable with gastric outlet obstruction. These are the two options that you have. If it is inoperable, it all depends upon the site where it is going to be present. So we will see whether it is present in the proximal part of the stomach, whether it is present in the mid-body part, or whether it is in the distal part of the stomach, right? Now, it all depends upon that how we are going to cater if it is going to present at different sites. Okay? Now, if it is present in the proximal, if it is in the mid body, or whether it is going to be in a distal part of the stomach. For proximal stomach, it is going to be a total gastrectomy. With D2 lymph node clearance. Mid body will again go ahead with almost total gastrectomy. We'll do a total gastrectomy with D2 lymph node clearance. For distal, it is going to be a partial gastrectomy. We'll do a partial gastrectomy with D2 lymph node clearance, right? So whenever you're doing a total gastrectomy, you have to create a reconstruction, right? So in a total gastrectomy, so we'll see the status after total and after partial gastrectomy. So you have the total gastrectomy and then you have the status after partial gastrectomy. So you have the total gastrectomy and the partial gastrectomy. So this is the esophagus. This happens to be the stomach. This happens to be the duodenum, and the jejunum would continue across here. In a total gastrectomy, I am removing the stomach completely. So this much amount of the intestine is lost. So this much amount of the stomach is being removed. Now when you remove this much amount of stomach, what are you left out with? You are left out with the esophagus and the duodenum and the rest of the jejunum. So what I'll do is, I will close the duodenal stump. I will close the duodenal stump is going to be closed completely, right? Now once the duodenal stump is closed, what I'll do is I will isolate the jejunum. So I'm going to take the jejunum out. So what I'll do is I will isolate the jejunum. That means I'll cut the jejunum here. So once I cut the jejunum here, now I have the two loops of the jejunum. The one that comes first is what we call it as the proximal end of the jejunum, and this is what the distal end of the jejunum is. I will mobilize the distal end of the jejunum. So the distal end of the jejunum is going to travel. It will reach all the way here, and I will make an anastomosis with that of the esophagus, and this is the jejunum which is going to be taken across here. And you see, as the jejunum continues to travel, this end of the jejunum will be anastomosed with the rest of the jejunum, and this continues to go, right? This surgery where you have anastomosed the esophagus. So this is the esophagus, this is the jejunum. This is what we call it as the Roux-en-Y esophago. Roux-en-Y esophago jejunostomy. It is Roux-en-Y esophago jejunostomy. It's a Roux-en-Y esophago jejunostomy. Clear? So now you know what is the Roux-en-Y surgery is. So in the Roux-en-Y, you divided the jejunum into proximal and distal end. The proximal end is still left here. This is the proximal end. This is the distal end, which is taken up all the way to the esophagus, and then here at the level of the esophagus, they have made an anastomosis. This is what we called as the esophagojejunostomy. Now why you have left here is the duodenum part, because this common bile duct opens onto the second part of the duodenum. So you want the bile to flow across here so that the bile can go into the food, and whenever the patient is going to eat, whatever he eats, the food is going to come from here, enters into this part of the jejunum, and together it can travel. So you have created two limbs. One is called as the biliary limb, another one is what we call it as the food limb, and together they move together, and then it just goes in, right? So this is what you do in a total gastrectomy. You know, total gastrectomy. Clear? Clear, guys? Okay. So Roux-en-Y is important when you do a total gastrectomy. Now what changes in a partial gastrectomy is, one second, guys. Okay. So in a partial gastrectomy, when you look at this, same thing, nothing changes. In a partial gastrectomy, this is the part of the stomach. And the same thing, you have the duodenum, you have the jejunum, everything is going across here, nothing has been changed, right? Let's say there's a tumor which is present here. That is in the distal 1/3 of the stomach. Now the basic rule here is, when you take, this is the upper margin of the tumor, this is the lower margin of the tumor, there's something called as proximal and distal margin. Remember, in carcinoma stomach, the proximal margin of the stomach has to be 5 centimeters and the distal margin of the stomach has to be 5 centimeters. So tumor के ऊपर 5 सेंटीमीटर, ट्यूमर के नीचे 5 सेंटीमीटर निकालना जरूरी है, ठीक है, ये बेसिक है. So उसकी वजह से क्या होगा, what is going to happen, I'm going to remove this much amount of the stomach is going to be removed. So this much amount of the stomach is going to be lost. So what I'm left out with, there's a part of the stomach which is left behind, which is here. Okay. Now again same thing, I'm going to close the duodenal stump. So duodenum को हमने बंद कर दिया. I have divided the jejunum right across here. तो jejunum को divide कर दिया. Jejunum को divide करते ही हमारे दो लिम्ब बनते हैं, जैसे हमने पहले बताया था. ये आपका proximal limb है, ये आपका distal limb है. Proximal limb में आप देख रहे हो कि आपका bile duct is opening and this is where the bile is going to come. तो मैं क्या करूँगा, distal limb को migrate करा दूँगा. So when I take the distal limb, I'm going to pull the distal limb. Distal limb को यहाँ पे आपने announce करा दिया. So this is where the distal limb, again it is closed. यहाँ पे stomach की opening है, आपने jejunum को side में open किया, and then you made an anastomosis of the stomach with that of the jejunum. So gastrojejunostomy में end to side anastomosis होगा, end of the stomach to the side of the jejunum, end to side anastomosis. बाकी आपका जो jejunum है उसको लेके नीचे चले गए, तो jejunum जा रहा है जा रहा है जा रहा है. This is how the jejunum is traveling. और ये जो आपका proximal end of the jejunum है, इसको आप इसके साथ मिला दोगे, and then you will allow it to continue across here. So same story, ये आपकी proximal end of the jejunum है, ये आपकी distal end of the jejunum है. You will see the bile duct which has been opened out of the second part of the duodenum will allow the bile to flow. So ये bile flow हो गया. Patient जब खाना खाएगा, whenever the patient is going to eat the food, that food is going to enter via the stomach into the jejunum and the food will continue to travel, and from here it will become a common channel. From here you will see both food and bile is going to mix together and go together, right? Now this surgery is what we call it as Roux-en-Y gastrojejunostomy. This is what we call it as the Roux-en-Y gastrojejunostomy. If you want to impress your examiner, you can say this is an end to side anastomosis. This is an end to side anastomosis. Okay? So this is how you're going to talk about the management of your carcinoma stomach. You can also add the last nail in the coffin, that is a post-operative chemotherapy. So in a post-operative chemotherapy, the regime is going to be ECF, that's the mnemonic. E stands for epirubicin. C stands for cisplatin. And F stands for 5-fluorouracil. So epirubicin, cisplatin, 5-fluorouracil, these are the components for your CA stomach. Clear? So an elaborate discussion पूरे carcinoma stomach में, from its risk factor to its clinical presentation, typical, atypical. इतना लिखोगे तो लोग पागल हो जाएंगे. ठीक है? Clear? Clear guys? So we finished the first question, which was of 10 marks. That is going to be carcinoma stomach, right? So done with CA stomach. So next we go with Meckel's diverticulum. So Meckel's diverticulum is actually a short note. So we'll quickly talk about the Meckel's diverticulum. So talk about Meckel's diverticulum. Remember, Meckel's diverticulum, it's a congenital diverticulum. It is a congenital diverticulum formed due to the remnant of vitalo-intestinal duct. due to a remnant of vitalo-intestinal duct. So it's a congenital diverticulum formed due to a remnant of vitalo-intestinal duct, and that is what we call it as the Meckel's diverticulum. Now, when you look at the whole concept, this is where the yolk sac is going to be present. This is your vitalo-intestinal duct, and through the vitalo-intestinal duct, you see the bowel is going to arise. So this is how this is going to arise. Normally, we expect, if you take this as the yolk sac, this is the vitalo-intestinal duct. This is the vitalo-intestinal duct, and this happens to be the bowel loop. Normally, this yolk sac and vitalo-intestinal duct should disappear. In few patients, this persists. So the persistence of this vitalo-intestinal duct on the bowel segment, is what we call it as the Meckel's diverticulum. So this is what we call it as the Meckel's diverticulum. This is a Meckel's diverticulum, right? So talk about the important points about the Meckel's diverticulum. Remember, this is an example of a true diverticulum. This is an example of a true diverticulum. This arises from anti-mesenteric border. This arises from anti-mesenteric border. And remember, they follow something called as the rule of 2. So what is the rule of 2 in the Meckel's diverticulum? So in the rule of 2 of the Meckel's diverticulum, number 1, it is present in 2% of the population. It is present in 2% of the population. That is why this is the most common congenital. This is the most common congenital abnormality of the bowel. This is the most common congenital abnormality of the bowel. How long it persists? It will persist until it is removed. Correct, beta. So it's formed is formed. It's not necessary that every patient of Meckel's diverticulum will become symptomatic. No. In fact, less than 10% of the patients who have Meckel's diverticulum become symptomatic. Rest of them remains asymptomatic for life. So it's 2% population. It is going to be 2 inches in size. This is going to be 2 inches in size. This is going to be 2 feet approximately. That is 60 centimeter proximal to ileocecal junction. It is 2 feet proximal to IC junction, and it has got 2 different mucosa. So it can have ectopic gastric mucosa. It can have ectopic gastric mucosa and ectopic pancreatic tissue. So then ectopic gastric mucosa as well as ectopic pancreatic tissue. So this is the rule of 2 that is present in Meckel's diverticulum. So we talk about the clinical features. Clinical features associated with Meckel's diverticulum. Now remember, most of the patients are asymptomatic. Most of the patients are asymptomatic. They are asymptomatic for life. Only 10% of the patients are symptomatic. Only 10% of the patients are symptomatic, and these 10% of the patients are symptomatic. These are due to complications. These are due to complications associated with Meckel's diverticulum. Aviril, there is no risk factor per se. There is no proven risk factor. It's a congenital abnormality that is found. Okay. So it's mostly asymptomatic for life, but then 10% of the patients may present to you with symptoms. Now, when I say 10% of the patients may present to you with symptoms, what are the symptoms that you're looking at? Now, when we talk about the Meckel's diverticulum, many a times now we just jump into conclusion saying the Meckel's diverticulum will be present as it is. No, it is not. You need to understand that it is going to have a feature which is going to be associated with bleed. It is going to have, see, you have ectopic. I'm not okay. Let's not try to overcook this. I'll say simply the complication that can present to us presentation. We'll talk about the complications of the Meckel's diverticulum, which will present to you as clinical symptoms or clinical presentation. As I told you, only 10% of them are going to be symptomatic, and those are due to complications. I can divide the complications in 3 factors. One is bleeding, another one is obstruction, and one more is going to be diverticulitis. Right? So one, it will present to us bleeding, another one will present to us obstruction, and one more it is going to present to us diverticulitis. Okay? Now when I say bleeding, why would a Meckel's diverticulum bleed? And this is quite interesting for us to know as well. Now the bleeding in the Meckel's diverticulum, it is secondary to the peptic ulcer disease in an ectopic gastric mucosa. So this is due to peptic ulcer disease in the ectopic gastric mucosa. Ectopic gastric mucosa. Now when it bleeds extensively, it is going to present to you with melena. It can present to you with fresh blood, that is hematochezia. And obviously extensive blood loss will also result in anemia. So lower GI bleeds, right? Melena, hematochezia, as well as anemia are going to present. So this is about the bleeding. It can also present to you as obstruction. So obstruction, how does Meckel's diverticulum cause obstruction? Remember, Meckel's diverticulum is the most common, it is the most common lead point, it is the most common lead point in children for intussusception. For an intussusception. So here the obstruction is due to intussusception. What is intussusception? I'll talk in a bit. Okay? So intussusception, you see one loop of the ball going into another. Now when it comes down to diverticulitis, now diverticulitis is any itis is inflammation. No, any inflammation is going to have Ruber-Kaller-Dollar tumor. Any inflammation is going to be Ruber-Kaller-Dollar tumor. Same thing is going to happen. Now that terminal ileum part is present in the right iliac fossa, and the inflammation in the right iliac fossa will present to you patient with pain in right iliac fossa. There is right iliac fossa tenderness. Now because any bowel inflammation will be associated with nausea as well as vomiting, that is going to be present. So there is pain, there is tenderness, there is nausea, vomiting. It will be associated with fever as well. Now imagine a patient is having pain in the right iliac fossa, tenderness in the right iliac fossa, nausea, vomiting as associated with that, there's a fever. All that usually points with the most common differential diagnosis, that is going to be your acute appendicitis, right? So what is the most likely embryological explanation with the percent of gastric mucosa with the Meckel's diverticulum, and how does it relate to the risk of developing of GI bleed? See, Aviril, when you talk about the ectopic gastric mucosa, it's the migration of the neurocrest cells during the embryonic development that happens, right? The exact pathophysiology is not very well unfolded, but it has been found that Meckel's diverticulum harbors, it's all when you talk about the derivatives. No, you have the foregut, midgut, and hindgut derivatives. The foregut develops all the way to the second part of the duodenum. The midgut develops from there onwards all the way to that of the transverse to the colon, and the rest of the hindgut is there. Normally, you talk about pancreas, you talk about gastric mucosa, they are foregut derivatives. So when that derivative component comes into the midgut and it remains or sustains with the vital intestinal duct, that is going to present to you as ectopic gastric mucosa or ectopic pancreatic tissue. Now why does it happen? I really don't know. Now why will a patient develop a risk of bleeding? Because when there is a gastric mucosa, now you know H. pylori, we will talk about it. H. pylori has a very high affinity towards gastric type of mucosa. It can only grow in gastric type of mucosa, nowhere else. Now imagine a patient is infested with your H. pylori, the patient will have peptic ulcer disease in the stomach. The same H. pylori nowhere else in the intestine can grow, but can grow in the Meckel's diverticulum because of the presence of your ectopic gastric mucosa. There it causes peptic ulcer disease, and peptic ulcer disease, erosions will be there, erosion cause bleed. So hence that bleeding is secondary to the peptic ulcer disease in gastric mucosa. Okay? So when the patient develops diverticulitis, the diverticulitis, it is the most common differential. This is the most common differential diagnosis. This is the most common differential diagnosis for acute appendicitis. It is the most common. This is the most common differential diagnosis for acute appendicitis. Okay? So these are the complications. So how does the patient present to you? Patient can present to you with lower GI bleed, that is melena, hematochezia, anemia. It can present to you as intestinal obstruction. It can also present to you as features suggestive of acute appendicitis. Okay? Now, when you talk about Meckel's diverticulum, what are the investigations that you can do? The investigations that you can do, number one is the ultrasound of the abdomen. We can do a CECT of the abdomen. But more importantly, it is the technetium 99 per technate scan. Which is most effective. Now, now technetium 99, it has got very high affinity. It has got very high affinity for gastric type of mucosa. It has got very high affinity. It has got very high affinity for the gastric type of mucosa. Hence, you'll be able to see Meckel's diverticulum. So, whenever you have a patient with Meckel's diverticulum, management, remember, if it is incidentally found, or if the patient is presented with complications. If the patient is presented with complications in Meckel's diverticulum, then it has to be resection and anastomosis. That is diverticulectomy. We'll do a diverticulectomy with primary anastomosis. So we'll excise and anastomose. Now talk about the incidentally found. When you have the incidentally found Meckel's diverticulum, what are the indications for surgery? Now the current indication for surgery, number one, if the age less than 50 years. Number two, if it is a male sex. If the length of the diverticulum, is more than 2 centimeters. If there is presence of ectopic tissue, that means when you did a technetium 99, there is a positive uptake. And if there is any palpable abnormality. This also remains the same, that is a diverticulectomy with primary anastomosis, right? So this is how you are going to address your Meckel's diverticulum. Okay? So we have finished your second topic also, that is your Meckel's diverticulum. Now we'll go with intestinal obstruction and the intussusception in the same consensus so that we understand it better. So the next question that you have is about intestinal obstruction. Right, so when you talk about the intestinal obstruction, let's classify the intestinal obstruction per se. So when you talk about the intestinal obstruction, when we talk about the intestinal obstruction can be divided into two categories. It can be divided into two categories. One, it is a dynamic intestinal obstruction. One, we have a dynamic intestinal obstruction. Another one is our adynamic intestinal obstruction. It's a dynamic intestinal obstruction. Another one is going to be adynamic intestinal obstruction. So what is the basic difference between a dynamic and an adynamic intestinal obstruction is, you take this as a representation of the bowel. This is the bowel loop that we have. Inside this, this is the bowel wall. This is the bowel wall that you have, right? So these are the loops of the bowel that you have. Now, what is a dynamic and an adynamic intestinal obstruction is, let's imagine that this is the proximal end of the bowel, this is the distal end of the bowel. We all know the content is going to move in this particular direction. In a dynamic bowel obstruction, due to some reasons, there is an obstructive lesion which is present inside the, somewhere across here in the lumen itself, there is an obstructive component. Now, because of this, what is going to happen? The content that is supposed to go, anything that is moving inside the intestine cannot move, and will start pooling. And this back pooling of the content inside the intestine is what we call as dynamic obstruction, because there is some visible mechanical obstruction which is not allowing the content to move forward. On the other hand, in adynamic intestinal obstruction, the lumen is absolutely fine, but you will see that there is loss of peristalsis. The bowel wall does not have any peristalsis. Now, because the bowel wall does not have any peristalsis, the content is going to stay in its place. It cannot move any further. So the movement does not occur because there is no peristalsis. Hence, what is an obstruction? Where a content is not able to move from proximal to distal, it is getting stuck. Right? That is what the obstruction is. Either there has to be a dynamic or there has to be an adynamic cause. Dynamic is going to be a visible mechanical obstruction. Adynamic is simply loss of peristalsis. This is what you have to understand. Is that clear? Okay. Now, coming to the dynamic intestinal obstruction, the dynamic intestinal obstruction depends where exactly the obstruction is going to occur. Is it going to be intraluminal? Is it intraluminal? Is it going to be intramural? Or is it going to be extraluminal? Is it going to be extraluminal? Right? Now, what do you mean by an intraluminal? So, if you take this is the bowel wall. So, the inner wall that is there. This is your intramural. And this is your extraluminal. Now, intraluminal, you see the obstruction is here. Intramural, it originates from the wall and then causes the obstruction. Extraluminal, you see something is exerting pressure from outside, and because of this, now you can see the lumen is getting obliterated, right? So there are three varieties. There are extraluminal, extramural, and extraluminal. Okay? Now, what are the causes that will result in an intraluminal obstruction? Number one is your fecal impaction. Number one is a fecal impaction, foreign body. Fecal impaction, foreign body, all the bezoars, that is trichobezoar and phytobezoar. Then gallstones. So fecal impaction, foreign body, trichobezoar, phytobezoar, and gallstones, all these are going to result in dynamic bowel obstruction. That is a intraluminal. What is intramural? One that is arising from the wall, all the stricture, all the malignancies, all the stricture, all the malignancies, intussusception, and volvulus. All these are intramural. What are extraluminal? It could be bands or adhesions. Bands or adhesions, or it could be hernia. It could be hernia, right? So these are the causes for extraluminal bowel obstructions. Okay? Now let it be any extraluminal, interluminal, intramural, any form. The clinical presentation is going to be similar. So we'll divide the clinical features into two categories. One is with the dynamic bowel obstruction, clinical features of the dynamic obstruction in comparison to that of a dynamic obstruction. So our clinical features, where you have one is dynamic obstruction, another one is your adynamic bowel obstruction. One is going to be dynamic, another one is going to be adynamic bowel obstruction. So when we say dynamic bowel obstruction, number one, there will be colicky abdominal pain. There will be colicky abdominal pain. It will be associated with nausea and vomiting. It will be associated with nausea and vomiting with non-passage. There will be non-passage. There will be non-passage of stools and flatus. There will be non-passage of stools and flatus. There will be increased bowel sounds. That is intensity of the bowel sounds. There will be earlier intensity, but after there will be bowel fatigue, it will stop. But usually in the earlier phase, there will be an increased bowel sounds, I can say intensity increases. So colicky abdominal pain, nausea, vomiting, non-passage stools and flatus, increased bowel sounds or increased intensity of the bowel sounds are noticed, right? So all these are going to be present in the dynamic bowel obstruction. See, the concept of adynamic bowel obstruction is there are no peristalsis. So the pain in dynamic bowel obstruction is because of intense peristalsis to overcome the obstruction. Here peristalsis are not there. So here patient will have abdominal discomfort. Here the patient is going to have an abdominal discomfort. Now as the content cannot move forward, it is now going to move backward, resulting in nausea as well as vomiting. Again, no peristalsis means no passage. There is non-passage of stools and flatus. So non-passage of stools and flatus. And how do you know it's an adynamic bowel obstruction? The bowel sounds will be absent. The bowel sound will be absent. One thing that you remember is in a large intestinal obstruction, there will be massive abdominal distension. In the large bowel obstruction, there will be a massive abdominal distension. There will be a massive abdominal distension because large bowel obstructions are closed loop obstructions. They are the closed loop obstructions. Now that context, we'll talk about intussusception. So talk about intussusception. So talk about intussusception. It is described as intussusception is it's a form of dynamic bowel obstruction. It's a form of dynamic bowel obstruction due to the proximal end of the bowel. To the proximal end of the bowel telescopes into the distal end of the bowel. Into the distal end of the bowel. When the proximal end of the bowel telescopes into a distal end of the bowel, this is what we call it as intussusception. Now just for the sake of understanding, in a graphical representation, if I put, this is how a bowel would look like. Let's say this is the representation of the bowel that you have. Now, due to some reason, if I just simply divide this end of the bowel, we'll say this is the proximal end, this is the distal end, and I'm saying the proximal end of the bowel is going to telescope into the distal end. Once it telescopes into the distal end, what is the end result that you have? In the end result, you see that this end of the bowel is going to go inside and it is going to get accommodative. This is what we call it as intussusception. When the proximal end of the bowel telescopes into the distal end. So this is the proximal end of the bowel. This happens to be distal end. The distal end is accommodating the proximal end of the bowel, and this is what we call it as intussusception. Now the part of the bowel that has gone inside, this is what we call it as intussusceptum. The part of the bowel that has gone in is what we call it as intussusceptum. And the part of the bowel that is accommodating this is called as the intussuscipiens. So this end of the bowel, which is taking this entire segment in, this is what we call it as the intussusceptum. This entire end is what we call it as the one that is going in. The proximal end will be called as intussusceptum. So this is the intussusceptum, and one that takes in, this is called as the intussuscipiens. So the intussusceptum and the intussuscipiens, right? So what is going to happen is the vascularity of the bowel part which has gone inside, it is going to get compressed, hence it is going to undergo tissue necrosis. You don't want that to happen. Now, not everybody can develop an intussusception. So what are the risk factors? So the risk factor for development of intussusception goes by a concept which is called as a lead point. Now, lead point is defined as it's the point from where intussusception begins. It's the point from where the intussusception begins. It is the point from where the intussusception begins, and that's what we call it as the lead point. Okay. Now, what are the examples of the lead point? Remember, in an age less than 1 year, it is usually hypertrophied Peyer's patches. It is your hypertrophied Peyer's patches. It is a hypertrophied Peyer's patches post rotavirus infection. It is the hypertrophied Peyer's patches post rotavirus infection is what is the most important lead point. Okay? So that is age less than 1 year. In children, the most important or the most common lead point is going to be Meckel's diverticulum. What is Meckel's diverticulum? In adult, it can be secondary to polyps. Tumor in children. Which will cause intussusception, causing intussusception is the small intestinal lymphomas. So look at it, age less than 1, hypertrophied Peyer's patches, children Meckel's diverticulum, adult it is polyp, and tumors in children causing intussusception is going to be a small intestinal lymphoma. All these act as lead point. Okay? Now, how does the patient present to you? Now, in the clinical presentation, remember, in children, it is usually ileocolic intussusception. In adults, it is going to be colocolic intussusception. In children, it is ileocolic, and in adults, it is your colocolic intussusception. As simple as that. Now, when we look at the whole scenario, let's talk about the clinical presentation that you will see. In the clinical features, any intussusception is going to present to you as dynamic bowel obstruction. They will present to you as dynamic bowel obstruction. So in the dynamic bowel obstruction, patient is going to have, number one, colicky abdominal pain. They have the colicky abdominal pain. It is associated with nausea, vomiting. It is associated with nausea as well as vomiting. There is non-passage. There is non-passage of stools and flatus. There is non-passage of stools and flatus. So the colicky abdominal pain, nausea, vomiting, non-passage of stools and flatus. And here the bowel sounds are usually present with increased intensity. That's the first presentation that you have for dynamic bowel obstruction. Now, if I change this to age less than 1 year, so in age less than 1 year, what will be the presentation? Here the baby is going to have an extensive cry. There's an extensive cry. When you palpate, there will be an empty right iliac fossa. There's an empty right iliac fossa. It results in sausage-shaped abdomen. And sometimes there's a spontaneous resolution of intussusception in children specifically, and there they'll be present with red currant jelly stools. There will be presence of red currant jelly stools. So extensive cry. There's an empty right iliac fossa, sausage-shaped abdomen, and the red currant jelly stool. All these are going to be seen. Now, once you have, for any intestinal obstruction, the protocol for investigation is quite simple. Any intestinal obstruction, the first step, it is going to be an erect X-ray abdomen. Especially in children, you have to go with USG abdomen and conclude by doing a CCT abdomen. So do an erect X-ray abdomen, then you do an ultrasound abdomen, and then you have CCT abdomen. Now, specifically when you do a contrast imaging, there is a specific sign which is called as the claw sign in intussusception. In the ultrasound, you will see this presence of target, or also called as the donut sign. They called as the target or the donut sign, right? So this is on the investigation. Management is going to take the patient for exploratory laparotomy and relieve the intussusception. Exploratory laparotomy, resolve intussusception, resolve the intussusception by milking from distal to proximal end. So once you do this, if there is a non-viable bowel, so once you have done the milking, if there is presence of a non-viable bowel, then go ahead with resection and anastomosis. Then go ahead with resection and anastomosis. Then go ahead with resection and anastomosis, right? So this is all that you should do. This is all that we should do with respect to intussusception. Okay, so we have finished 2 other topics as well. What are 2 topics that we had? Intestinal obstruction as well as intussusception. So there were 3 small topics, 1 big and 2 small. That is our CA colon, and then you have hemorrhoids and Fistula-in-ano. So start with the cancer colon. Right. Talking about the cancer colorectal. Cancer colon as well as rectum, we'll talk about both here. Now, when you talk about the cancer colorectum, by incidence, you should know where do you have maximum, right? Now, if you take this as the representation of the ascending colon, let's say this happens to be the cecum, this is the appendix, this is the terminal ileum. This is the hepatic flexure. This is the transverse colon, this is the splenic flexure. See, anatomically my drawings will be very precise. You'll see the splenic flexure is at a higher level when compared to hepatic flexure. This is the descending colon. This happens to be the sigmoid colon. This happens to be the sigmoid colon. As you will see, sigmoid colon will be the narrowest part. This is going to be rectum and the anal canal, right? This is the whole objective that you have. Now, when you look at the entire incidence, I can just quickly talk about the malignancies at the cecum. The cecum consists of 12% of the total cancer colons. Ascending colon, consists of 5% of the total one. Hepatic flexure is 2%. Hepatic flexure is 2%. Transverse colon. Transverse colon is approximately 5.5%. Splenic flexure is 3%. Descending colon. Is going to be 4%. Sigmoid colon. Sigmoid colon will be 21%. Rectum is going to be 38%. Right. So you look at the whole arrangement. No, you will notice the maximum incidence of the entire colorectal cancer around 38 plus 21%. No, sigmoid colon is 21%. Right, so almost 59% of the entire, 60% of your entire colorectal cancer is there in the rectosigmoid region. It is just there in the rectosigmoid region. So this is where you will usually see. So majority of times you see a colorectal cancer, they will be presented with left-sided colonic features, right? Now what are the risk factors that you're looking at? The risk factors for colorectal cancers. Number one, it is dietary risk factor, that is increased animal fat. Increased animal fat and low fiber diet. This is a low fiber diet. Increased animal fat and low fiber diet. There are genetic components. In genetic components, we have familial adenomatous polyposis. It's the familial adenomatous polyposis, which is called as FAP. Then you have Gardner syndrome. You have the Gardner syndrome, Turcot syndrome, Then you have the Lynch syndrome. That is your Lynch 1 and Lynch 2. That's your Lynch 1 as well as your Lynch 2. These are genetic risk factors. Then presence of adenomatous polyps. Presence of the adenomatous polyps. Then you have inflammatory bowel disease, where ulcerative colitis and Crohn's disease cause equal incidence. History of pelvic radiation. History of pelvic radiation, right? So these are the important risk factors. Now talk about the pathophysiology of the colorectal cancers. So when you talk about the pathophysiology of the colorectal cancers, see, the whole journey starts with a normal colonic epithelium. So initially you have a normal colonic epithelium. In this colonic epithelium there will be presence of dysplasia. This dysplasia will now convert into an adenoma. There are different phases of adenoma that is going to occur, and from eventually it is now going to convert into carcinoma. So you'll see this is initially there will be some amount of dysplasia that will present. So this is your dysplasia. Now from the dysplasia it is now going to form into an adenoma. So there's an adenoma which is present. This is a late adenoma. From there it is now going to become into carcinoma. This is the journey that you need to understand. From a normal colonic epithelium to dysplasia. From a dysplasia to early adenoma. From an early adenoma to that of the late adenoma. And from the late adenoma to that of carcinoma, right? So normal, dysplasia, early adenoma, late adenoma, and eventually becoming into carcinoma. Now what results, or I can say what leads the whole journey? From a normal colonic epithelium to a dysplasia, it is because of APC gene mutation. From dysplasia to that of adenoma, that is going to the whole journey where you can say the dysplastic lesion from early adenoma, early to intermediate, and then to the late adenoma. There are two genes which are going to be responsible for this whole transformation. One is your KRAS mutation, another one is your DCC. From the late adenoma to that of carcinoma, it is because of P53 gene mutation. So APC gene mutation takes from normal to dysplasia, from dysplasia to early adenoma, and the late adenomas are because of KRAS and DCC, and from there late adenoma to carcinoma is because of P53 gene mutation. It is because of P53 gene mutation. Clear? So talk about the clinical features of colonic or colorectal cancers. So clinical features of the colorectal cancer. So we have the colorectal cancer, can divide them into two varieties. One is your right-sided colonic cancers. Another one is the left-sided colon cancers. One is a right-sided colon cancer. One more is a left-sided colon cancer. Now, morphologically, when you talk about just based on the morphology, right-sided colonic cancers will be of two varieties. Number one is your ulcerated lesion. Another one is your cauliflower lesion. The ulcerated lesion and the cauliflower lesion. For the left-sided colonic cancers, it is the tubular lesion and the stenosing lesion. It is the tubular lesion and the stenosing lesion. So morphologically, Morphologically, you have two varieties. Ulcerated lesions, cauliflower on the right side, tubular and stenosing on the left side. Now, in terms of clinical presentation, remember the right side colon cancers are going to present to you as lower GI bleeds. They'll present to you as lower GI bleed, and this lower GI bleed will be associated with melena. It is usually associated with melena, hematochezia. It is melena, hematochezia, as well as anemia. With that, it will also be associated with significant weight loss. Whereas the left-sided colonic cancers, they will usually present with bowel obstructive features. So they will start with constipation. Then there will be tenesmus, that is urge to defecate but unable to defecate, melena, hematochezia. Melena, hematochezia, early morning spurious diarrhea. So usually when the tumor blocks the lumen, all the all the stools, all the content of the colon gets accumulated above that, and all the tumor secretions overnight will pool, and then it will liquefy the stools, and early morning there will be spurious diarrhea. So early morning spurious diarrhea is actually a feature of your left side colonic cancer, and they usually present with large intestinal obstruction, usually dynamic obstruction. In terms of investigations, number one, we have to do a colonoscopic biopsy. Colonoscopy with biopsy. You have to also perform the PET-CT, which is for staging. PET-CT is for staging. Now there is a staging that we follow, which is called as the Duke's staging. In the Duke staging, we have Duke stage A, where the tumor invades mucosa and submucosa. Tumor invades mucosa and submucosa. Then there is B1, that is tumor is between submucosa and serosa. Tumor between submucosa and serosa. B2 is tumor beyond serosa. C1 is B1 with lymph node involvement. C2 is B2 with lymph node involvement. And D is your distant metastasis. D is your distant metastasis, right? So this is your Duke staging. Now how do you manage? So management is depending upon the location of the tumor per se. So we'll quickly run through that. Right. So based upon the tumor, if it is in the ascending colon, if in the ascending colon, or if it is in the cecum. then it's going to be right, this is your right side, this is your left side. So here it is going to be right radical hemicolectomy. It is a right radical hemicolectomy. Now, if the tumor is in the hepatic flexure, if the tumor is in the hepatic flexure, it is going to be extended right radical hemicolectomy. So extended right radical hemicolectomy. If it is in the transverse colon, if it is in the transverse colon, then the surgery is still the same. So I can say for both of them, that is going to be right radical hemicolectomy. If it is on the splenic flexure, then he'll do left or extended left radical hemicolectomy. If it's on the descending colon, if it's a descending colon, there is a left radical hemicolectomy. Sigmoid colon, it's a sigmoid resection. It is your sigmoid resection. If it is in the rectum, if it is the rectum, then see the lower margin is 5 centimeters from the anal virgin out. So if the lower margin is about more than 5 centimeters from anal verge, or if the lower margin is within 5 centimeters from the anal verge, right? But Amir, we will see that. I think I've sent all the notes. We'll ask them to upload it today. I personally will also upload on the Telegram, but I'll also ask the team to upload again if they have not. Now, when you talk about the lower margin, which is more than 5 centimeters from the anal verge, then you'd go ahead with resection and anastomosis. You'll go ahead with resection and anastomosis. If it is within 5 centimeters, then you have to do an APR. That is your abdominoperineal resection. APR is an abdominoperineal resection, which is a permanent colostomy. It's going to be a permanent colostomy. Now, post-operative chemo regime that you have, we have Folfox and then you have Folfovir. Then that F stands for, that is FOL stands for folinic acid. F stands for 5-fluorouracil. OX stands for oxaliplatin. Here same, FOL stands for folinic acid. F stands for 5-fluorouracil. IRI stands for irinotecan. So I don't know. Okay. So these are Folfox and Folfoviri. So this is how you'll manage your colorectal cancers. So I finished a 10-mark question, which is here. So to talk about two topics, that is going to be hemorrhoids as well as your fistula. Chalo. So we'll talk about the Fistula-in-ano, and then we'll talk about the hemorrhoids. Again, short note in that. Now, Fistula-in-ano is described as it's an abnormal communication. It is an abnormal communication. It's an abnormal communication between the anal mucosa and perianal skin. It is an abnormal communication between the anal mucosa and the perianal skin, is what we call it as the Fistula-in-ano. This is what we call it as the Fistula-in-ano. Sorry. Now, what are the causes, or what results in the cause? So the cause of the Fistula-in-ano can be divided into primary and the secondary causes. We have the primary cause and we have the secondary cause. The single most important primary cause is incomplete or inadequate drainage of the perianal abscess or a spontaneous rupture of a perianal abscess. So it is either there is a spontaneous rupture. There is a spontaneous rupture of perianal abscess. There is a spontaneous rupture of perianal abscess, or there is an inadequate drainage of perianal abscess. So either a spontaneous rupture or an inadequate drainage, right? Hi Adya, good evening. Right, chalo. So in the secondary causes that you have, the secondary cause can be secondary to Crohn's disease. It can be secondary to the Crohn's disease. It can be secondary to tuberculosis. It can be secondary to radiation. So Crohn's, TB and radiation are the secondary causes. Now, based upon how they are, there's a classification which is called as a Parkes classification. Parkes classification of the perianal fistula. Now, according to the Parkes classification, if you quickly run through them, so this is the anal canal, the anal mucosa. This happens to be the perianal skin. There are two sphincters which are going to be present. It is the internal anal sphincter and the external anal sphincter. So let's say this happens to be your internal anal sphincter, and let's say this happens to be, your external anal sphincter. This happens to be the external anal sphincter, and let's say this is the rectum where it is going to start. So this is the rectum which is present. So here you have a muscle. That muscle is what we call it as the puborectalis. Right? So there's a muscular component which is here. So according to Parkes classification, there are different variants that you have. Type 1 variety, you see the inner. So this is your internal anal sphincter. So you'll see there's an inner opening here. It goes through the internal anal sphincter, travels between these two and opens onto the perianal skin. This is your one variety. The second variety, you will see it is piercing both the internal and the external sphincter, opening onto the perianal skin. This is your second variety. The third variety, you see the opening is in the inner half, but you see tract goes above this and then comes like this. This is what we call it as the suprasphincteric. And then one that is start from the rectal mucosa and opens across here. This is your fourth variety. So the first variety that is there, which is called as the intersphincteric variety. This is the intersphincteric type. Type 2 is the transsphincteric type. Type 3 is suprasphincteric. And type 4 is extrasphincteric. So you have intersphincteric, transsphincteric, suprasphincteric and extrasphincteric are the components of your Parkes classification. Any patient who has fistula-in-ano, their clinical presentation will be presence of cutaneous ulceration. There is presence of cutaneous ulceration in perianal region, in the perianal region. There will be a foul smelling discharge. There will be a foul smelling discharge. There will be fecal soiling of the undergarments. There will be fecal soiling of undergarments. And there will be history of perianal abscess. The history of perianal abscess. Now, investigation that you can do here is going to MR fistulogram. It can cause MR fistulogram. You can do an MR fistulogram. You can perform an endoanal ultrasound. Endoanal ultrasound. Management, if it is low fistula-in-ano, if it is a low fistula-in-ano, then you can simply go ahead with fistulotomy, or you can perform fistulectomy. If it is a high fistula-in-ano, then you will use a cutting sit-on. You will be using a cutting sit-on. So the points that you have to write with respect to fistula-in-ano, it's a short mark. Okay. Then is your hemorrhoids. Now when it comes to hemorrhoids, remember hemorrhoids are classified into two varieties. You have the primary hemorrhoids and the secondary hemorrhoids. The primary hemorrhoids are those hemorrhoids which arise from 3, 7 and 11 o'clock position, and secondary one is anywhere else than that. So if you take this as a representation of the clock, this is the 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock. This is how the clock is present. If a hemorrhoid arises from 3 o'clock, if it arises from a 7 o'clock, if it arises from 11 o'clock, it is primary. If it arises anywhere else than that, if it is arising anywhere else than that, this will be called as secondary hemorrhoids, right? So hemorrhoids, if it arises from 3, 7 and 11, it is primary. Anywhere else than 3, 7 and 11 is what we call it as the secondary hemorrhoids, right? In the same context, you have the internal and the external hemorrhoids. We have the internal hemorrhoids. We have the external hemorrhoids. Now, if the hemorrhoid is present above the level of dentate line, so if you draw this as the anal canal, and let's say this is the dentate line that you have. Now, if the hemorrhoid is present above the dentate line, it is internal hemorrhoid. If it is present below the dentate line, it is external hemorrhoid. So, above the dentate line, it is your internal hemorrhoid, and below the dentate line, this is your external hemorrhoid. Below the dentate line, it is your external hemorrhoids. Now, how would a patient develop a hemorrhoid? If you look at the overall context of it. So, the causes or the risk factors that results in development of hemorrhoids, the most important and the common one is constipation. Following constipation, pregnancy. Following pregnancy, if it is history of passing hard stools. Secondary to portal hypertension and connective tissue disorder. And the connective tissue disorder. The clinical presentation of the hemorrhoids is usually bleeding per rectum. That's the only presentation that they usually have. So when you want to evaluate this in investigation, I would do proctoscopy. Now, based upon the proctoscopy, we have grades of hemorrhoids. The grading is done on the basis of two things. Number one is bleeding. Number two is protrusion of the hemorrhoid. In a grade 1 hemorrhoid, the bleeding is present, there is no protrusion. In grade 2, there is presence of bleeding. The protrusion is present, but it spontaneously reduces. There is a spontaneous reduction. Grade 3, there is presence of bleeding. Grade protrusion is there, but it is manually reduced. It is manually reduced. Then it is grade 4, where bleeding is present, protrusion is also present, but here it is prolapsed. Here it is prolapsed. Management of the hemorrhoids. When it comes to grade 1, it is conservative management. Grade 2, we can do banding. Grade 3 and grade 4, we have to do surgery. Remember the surgeries that you can do. Number one is the Milligan-Morgan surgery, Ferguson surgery, stapler hemorrhoidopexy. So Milligan-Morgan, Ferguson and stapler hemorrhoidopexy. In conservative line of management, it is going to be laxative. It is going to be laxative, sitz bath, high fiber diet. So laxative, sitz bath and high fiber diet, right? So this is how